I welcome you all for today's webinar, Clinical Updates in Hepatobiliary and Genitourinary Cancers. With immense pleasure, I would like to invite Dr. A.P. Dubey, who is Senior Consultant, Unit Head, Medical Oncology at Metro Hospital and Cancer Institute, Preet Vihar, Delhi Metro Hospitals and Heart Institute, for the welcome and introductory note. The stage is all yours, sir. Thank you.
Good evening, everyone. I thank everyone for sparing out their time for this small CME. So I take this opportunity to invite and welcome my respected teacher, mentor, and guide, Dr. Major General B.N. Kapoor, to kickstart the program. So over to sir, Dr. Major General B.N. Kapoor, sir.
Thank you, Dr. Dubey, for inviting me to chair the session and to start the session. Very important topic has been selected for today's seminar. It's clinical updates in hepatobiliary and genitourinary cancer. A lot of advances are happening every day in oncology, and especially in hepatobiliary where the survival is dismal. So a lot of new things are coming up. Although we are not very successful in increasing the survival or prolonging the life, but still an effort is being made to increase it. And genitourinary, definitely, we have got very good drugs nowadays, and new drugs are coming to improve the survival or prolongation of life further. Without wasting any time, I would start the session, and I would invite Dr. Aparna Dhar. She's Director, Hereditary Precision Oncology and Genetic Counseling, Max Institute of Cancer Care, and she will be speaking on molecular profiling of biliary cancers. Dr. Aparna Dhar, please, are you there?
Yes, sir, I'm there. Good evening, everybody.
Yeah. Aparna, welcome to the session, and I invite you to speak on molecular profiling of biliary tract cancer. Dr. Aparna, please.
Thank you, sir. Good evening, everybody. Can we see my slides?
Yeah.
All right.
It is visible.
Perfect. All right. So thank you so much for having me here today and giving me the opportunity to speak on a topic that I'm really enjoying talking about of late. Once upon a time, molecular profiling used to talk about lung, NSCLC, and now it's that same kind of energy and that same kind of zest when it comes to biliary tract cancers. So when we think of biliary tract cancers, what do we think? We know they're rare, we know they're aggressive. The curative modality ideally is surgery, but if you have your non-surgical candidates, what do you do in a case like that? You consider systemic therapy, and around 15 odd years ago, we came up with the phase 2 trial, ABC-01 trial, where we said GEM-CIS would be the standard of care. Taking from there, there's been a lot of research, there's obviously been a lot of advances, and what we saw is to this concoction of GEM-CIS, if we add a PD-L1 inhibitor, so let's say we add what we got from the TOPAZ trial, if we added durvalumab, or that we got from the Keynote 966, if we added pembrolizumab, we saw that it did have a significant importance. It had a significant role in changing the PFS and OS of these very hard to treat cancers. And when a patient walks into our clinic over here and we see that, it's systemic therapy, it's unresectable metastatic disease. So today, when I look at these biliary tract cancers, I divide our patients into 3 buckets. One, those very classical cytotoxic chemotherapy. They're just going to respond to chemotherapy because that's just how the tumor is. In some cases, we know it's chemo with immuno where it works very well. And what we've now learned is that with the advent of next generation sequencing and with the availability of next generation sequencing, there are a plethora of actionable biomarkers. I know you're seeing MDM2 over there and wondering what on earth is it doing there. There's an amazing new drug, clinical trial. It's in phase 1 clinical trials, which is a potential TKI in the making. So there's a lot of great work that is happening here. And this is something that we started to see that's being reflected in our NCCN guidelines. So the more we started looking, the more we started searching, it was like opening Pandora's box. Now, Pandora's box always has a lot of chaos at first, and somewhere in the end, it has that very nice, sweet music, and it has a happy ending. And I like to believe that something like that is what we've understood about our biliary tract cancers. For the longest, we've thought our biliary tract cancers was this one subset of homogeneous disease, and we just said that, okay, it's biliary tract cancers, but what we learned is that it's actually a very heterogeneous disease. And you can't just club it as one big BTC. It actually has to be divided as per its anatomical site. And the reason dividing this disease as per the anatomical site became so critical and important, it's because we observed that the genomic, the molecular landscape was so unique and so distinctive to a particular site. And that's where we realized that molecular profiling was extremely important, especially in these very hard to treat aggressive cancers. So biliary tract cancers essentially were your intrahepatic, interhepatic, and gallbladder cancers. What we have seen in all of these is that gallbladders we tend to see more in females versus males. And, some of the key factors is like, the risk factors that we see is obesity, diabetes. They obviously have a very different presentation. A lot of it are incidental findings post a cholecystectomy. Your intrahepatic and your extrahepatic cholangiocarcinomas, this is where we could have the hereditary factor, which is Lynch syndrome. We do see your hepatitis B and C more prevalent in intrahepatic, and we see in extrahepatic, it's more common in males versus females. So, not unique distinguishing factors, but at the end of the day, these are hard to treat. Now, there was a very nice study by the Sloan Kettering group, and they took around 10,000 odd patients, and they just sequenced all of them. They just wanted to understand the mutational landscape. And what they saw right up, high up there in the top 5, top 7 were your biliary cancers. And they found that, yes, they were very heterogeneous. And in fact, a huge percentage of these molecularly matched to some targeted therapy. In addition, they saw that while they did this mutational landscape, these cancers, these biliary tract cancers, actually have a high mutational burden. Again, TMB, another important component. So when we look at the treatment paradigm that we are doing today in our clinic, as I said earlier, it's based on the anatomical side, you have your interhepatic cholangios where you see your FGFR2 fusions, not point mutations. Fusions, a very different somatic aberration. You've got to be a little careful over here. So it's your FGFR2 fusions, your IDH1 mutations, these are point mutations. We've got targeted therapies for them. You've got extrahepatic cholangios where we see a HER2. Now, again, it depends. Is it a HER2 point mutation? Is it your amplification? We've got trastuzumab, neratinib. There's some great work happening with trastuzumab deruxtecan. And then we've got those, those very typical agnostic markers that we tend to see across the board, BRAF, NTRK, MMR. And I've added NRG1 fusions because I've actually seen them in quite a few of our biliary tract cancers. In particular, I've seen it in gallbladder and extrahepatic, and these can actually be treated with very simple afatinib. So this is where we are with our current landscape. Now, when we do molecular profiling, like one of the key perks of doing it is, yes, knowing the targeted, a potential actionable biomarker, which can be treated with a potential drug. However, for me, I see molecular sequencing as a way of the tumor talking to us, telling us what is driving it, who are its components within this tumor. So sometimes it's not just about those point mutations that are actionable, but it's also about mutations that we can see. For example, if I see a CDKN2A, N2B loss, I see an MTAP loss, I know this particular, let's say, gallbladder cancer, where I've got a pretty decent PD-L1, is not going to respond very well to immunotherapy because this combination of MTAP loss, CDKN2A, N2B loss actually confers immunoresistance. It makes it.
Sorry to interrupt, Dr. Aparna. I think your slides are not moving, or you have not started moving it.
No, I've been moving it. I'm actually headed on my 10-12 slide already. Ooh. Uh-oh. Uh-oh. Okay. Organizers, can you just do it for me, please?
Yeah,
Yeah,
1
please.
second.
Sorry. Yeah, I've just stopped sharing. Sorry about that. Okay, so next. Next.
Yeah, now
I'm
it is
just gonna,
moving.
yeah, now it's moving. I'm going to directly go to where I stopped. Is that okay?
Yeah, it's okay. Yeah.
So next, please. Next, next, next. Some more. Next, 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 next. Stop. Okay, go back. That's it. Perfect. Thank you. So as I was saying, that when we are looking at the molecular profiling of these tumors, it's not just the targeted mutations. We also want to look at the other mutations because that's actually the way the tumor talks to us. And the better we interpret these so-called passenger mutations, sometimes we say it's got no role. What's its importance? It's actually really important because these mutations are helping us understand what's happening with the tumor. And the example I was giving was of a CDKN2A, N2B loss, which we do tend to see it quite often in these biliary tract tumors. And we see that with MTAP losses. And we know this makes it so-called immune hot because you had a high PD-L1, so you wanted to give immunotherapy, but it actually confers immunoresistance. It takes that tumor from being immune hot sensitive to immune cold. So you know immunotherapy is not going to work. Next, please. And these are just these various markers that we look at this, right? You've got your MEX, your KRASs, your PI3Ks, and these are what we see that are often, reported when we do NGS, when we do CGP, comprehensive genomic profiling for these biliary tract cancers, and especially our cholangiocarcinomas, we do see a host of these mutations that do pop up. And these are actually some well-validated results that are available based on which we can target and give a more precise way of treating our patients versus just sticking to standard of care. Next, please. Right, and the buck doesn't stop here. What we are starting to see, and which I showed earlier also, was that a lot of these biliary tract cancers, especially the cholangiocarcinomas, do have a potential hereditary influence. And it's not just Lynch syndrome. We're also starting to see a lot of BRCA1, BRCA2, and genes that are in the DNA damage repair pathway, whose role is DNA damage repair by homologous recombination. So in patients whose tumors have mutations in these potential germline or somatic, in these potential genes in the DNA damage repair pathway, there's a lot of great work happening where you can actually look at the HRD score, look at the genomic instability, and these patients can actually be good candidates for even PARP inhibitors. A good way of sensing and seeing that should I be sending my patient's tumor for HRD testing is their response to platinum chemotherapy. If you are seeing a good platinum response, you are identifying these potential platinum sensitive biomarkers, HRD might be a really good option to consider. Next, please. And this is what the NCCN guideline recommends. Very straightforward, these various mutations that we do commonly see mutated and what is the technique that we can use. Now, ideally with our real world setting, based on how limited the tumor content is, I would recommend doing NGS. Now, when we're doing next generation sequencing, we are looking for fusions. You're looking for those FGFR2 fusions. You're looking for the HER2 amplifications. Please ensure that your NGS panel does DNA and RNA sequencing. That gives you a full 360 view of the particular gene. And when I talk about comprehensive genomic profiling, and I've mentioned this a couple of times, it's not 5,000 genes, 500 genes, 200 genes. A comprehensive genomic profile is one which actually looks at a gene in particular and gives you a 360 view, which means you're looking at all the exons, you're going into the intronic region, which means you will be needing DNA and RNA. In addition, it looks at MSI, TMB, and PD-L1. So sometimes a good 100 gene panel can give you all the information you're looking for. So it's not just running about more the better, not always. In cases like this, we know those 100 good, well-validated panels does the job for you. Next, please. And then the common question that comes about is, look, the tumors sometimes can be difficult to access. Patients, they're just so exhausted with treatment. They don't want to do a rebiopsy. Is liquid biopsy an option? And this was an excellent study that was done by around some 10 odd institutes back in the US. There was Mayo, there was MSKCC, there was MD Anderson, and they used the Garden 360 platform. Mind you, this was the old platform, not the new Infinity platform that they've launched. And they took some 1,700 patients who were known cases of biliary tract cancers. When they profiled them, what they saw was that around 44% of them had an actionable somatic aberration. So these were targets that we could give some type of targeted therapies. What was even interesting was that liquid biopsy actually had a really good pickup rate for these IDH1 mutations. However, what they saw here, that picking up FGFR2 fusions were a little dicey. But I would say that this was done on the older panel where, yes, fusions on liquid biopsies are difficult to pick up. Irrespective, it's a foundation, a garden, they are a little difficult. But the new panel that is validated for garden, I'm not a spokesperson for garden, but what we have seen that the new panel does help address this lacunae in the technology with respect to fusions. Next, please. And there was a very similar study which went about where they looked at some 4,000 odd patients with cholangiocarcinomas on the foundation platform. So first was garden, this is foundation, this was tissue testing. And again, this echoed that especially in your cholangiocarcinomas, please do next generation sequencing. CGP, a good comprehensive genomic profile, actually resulted in 35% of these patients having some sort of actionable biomarker. And when I look at that actionable subset over here, 85% of them actually had FGFR2 fusions, which is targetable. Then I get a very common question. The drug is not available in India. What do we do? No worries. You have something like lenvatinib. If you cannot give the targeted pemigatinib, lenvatinib is another option. In addition, what we also saw was that in the cases of where we saw IDH1, PBRM1, we saw these ARID1A co-mutations. This was another class of drugs that could be possibly that could potentially benefit from a PARP inhibitor. And again, this was information that we were getting from a good CGP panel. Next, please. Next, please. And this is what the NCCN is also echoing. I think today, even the NCCN is pushing for next generation sequencing, CGP testing to help identify potential actionable biomarkers. Next, please. So sample type, tissue is the gold standard. It usually is, but tissue is an issue, or sometimes patients just decline testing. Next, please. We can consider liquid biopsy over here, but liquid biopsy has to be done from a good, well-reputed lab. I do understand cost constraints are there. Every patient cannot afford a garden, cannot afford a foundation, a Tempest. In those cases, please opt for a lab that has good validated data for liquid biopsies. A lot of time labs will say, oh, we did it on 10 samples, 20 samples. That's not sufficient. They need to have at least 50 to 100 odd samples where they've done a head-on-head comparison between the tissue and the liquid to show concordance based on which they've brought their particular liquid biopsy panel into circulation for our clinical practice. Next, please. And again, CGP testing, and these are the next 2-3 slides are actually just reiterating that the more we profile our patients, and again, I'm repeating, it's not 500, 600 gene panels. It's a simple 50 gene, 70 gene, 100 gene, good panel, which is giving you good coverage for your genes. It does drastically change the way we look after our patients. It does drastically change the PFS, the OS of our patients. And this was a very nice study where they looked at 121 patients that did complementary testing, where in some cases they had some patients opted for just tissue testing, some patients did just liquid, and then there were those who did both. And what they saw over here is, yes, there was concordance between the tissue and the liquid, but what was very interesting is that when they profiled from the new metastatic site, and especially when they did liquid biopsies, the pickup rate, because again, these are heterogeneous diseases, the pickup rate for actionable mutations was slightly higher versus just sticking to good old tissue. Next, please. And again, over here, what we did see is that those patients who were molecularly matched fared far, far better than those who were not molecularly matched. I think these Kaplan-Meier curves and they very beautifully illustrate this. So I'm not going to go much into it, but we do know that those who got matched did far better. Next, please. And I think this is how we treat biliary tract cancers today. It's looking at the whole picture. So when we are treating these very hard to treat aggressive tumors, it's important to look at everything. It's important to look at the DNA part, the RNA for your fusions, a combination of that in next generation sequencing. You want to look at your protein precision IHC markers, which is essentially your PDL1s. There are a host of others. I know there's a lot of work happening in Claudin 18, which is again an IHC marker. Great work happening there, not part of standard of care, but it's there. You want to look at your genomic signature, that is your loss of heterozygosity, your HRD scores, your TMB. And in addition to that, I think germline testing for our biliary tract cancers, especially for those who have a pre-existing BRCA1, BRCA2 mutation. Again, it's actionable and it also impacts the rest of the family. So this 360 view is extremely, extremely important in treating our biliary tract cancers. Next, please. And I think that slide best sums it up. I know we're not doing it very often. Cost is a constraint. There are many constraints that go about it. And one of the key concerns also happens is that I've done next generation sequencing. Now, what do I do with this report? Sometimes you just get a lot of information that may seem unnecessary, but I do feel that with biliary tract, with the kind of work that is happening, this phenomenal groundbreaking work, I just had 15 minutes. Otherwise, I could just go on and on about the great work and the great biomarkers that are around the corner that will hopefully improve the PFS and OS of our patients. Next, please. And on that note, thank you very much for your patient listening. I'm happy to take any questions, if any.
Thank you, Dr. Aparna. Very, very extensive. You have covered the topic, and very true that many things can be done in biliary tract cancer. Basically, in India, we have got so many patients, and we can do so much work in biliary tract cancers because the number we have got is extensive. So, very nice presentation. Yeah.
So with,
Well,
so with your
can I just add one comment? Sorry, I don't mean to interrupt.
Yeah, sure.
Sorry. So in fact, we last year, the Asia Pacific cholangiocarcinoma meet, we took the entire collective data from India. So we teamed up with lab partners. We teamed up with institutions like Tata Memorial Hospital, and we presented data of around 3,000, a couple thousand odd patients. And what was very interesting was to see that these are patients who had undergone genomic profiling. And one was, yes, a lot of our data was matching what the US was reporting. And we also learned, it was a good lesson for us, that so much of this was actually actionable because we maybe did not further interrogate the report. We may not have interpreted these reports better. But there was a lot of actionable biomarkers, maybe off-label, but there was a lot of great information that was coming out of them, which we know today could be practice changing. Sorry, Dr. Dubey, you were saying something I interrupted.
Yeah, sir, with your permission, sir, can I ask?
Definitely, Dubey.
Yeah, Dr. Aparna, no doubt, very well presented. I just wanted to ask, like, we as medical oncologists keep getting gallbladder cancers, that too in advanced or metastatic stages, where the most of the times it is adenocarcinoma, where you have very clearly explained that, yes, we should go for next generation sequencing. But sometimes in 5 to 10% cases, we have adenocarcinoma with neuroendocrine differentiation or neuroendocrine carcinoma or small cell carcinoma. Do we have to get the next generation sequencing on the tumor tissue for these subset of tumors too, or we have to hop on the chemotherapy only for this subset of the patients?
So I'm definitely going to say don't do away with chemo. Chemo is the backbone. A lot of times, even our targeted therapies or when we go off label, we always try and add physician's choice chemotherapy. What I will say with gallbladder cancers, and I do think the data is less because we kind of depend directly with the US as to what they are, reporting and what they are publishing. They don't see the amount of gallbladder cancers that we do in this part of the world. And I do personally feel that the more rarer the tumor, the more rarer the the pathology. I do think that these carry very unique genomic profiles. Is this going to be actionable? I cannot say that because I don't have definite data in front of me. But in our experience, I do feel that when the patient progresses on the first line, second line, that's a time in a cancer like this, which is non-adenocarcinoma. I would say give NGS a shot. You'd be surprised with sometimes what the system throws out. And we're seeing a lot of interesting mutations and, aberrations, which we don't associate with our biliary tract or even gallbladder in particular. So I do see a change, but I know it's not the most direct. It's a very roundabout answer. But I do think maybe if not upfront, unlike the others where I would say do it upfront, maybe after first line, if a patient is progressed.
I think we should do it. Probably in future, we will get more data in the clinical and the therapeutic options in such patients also.
Thank you, sir. Thank you, Dr.
Thank you very much. And we'll move on to the next talk. And next will be on newer update in the management of biliary tract cancer. And I do invite Dr. Surgeon Commander Kaushik from the Department of Medical and Oncology at INSHS Ashwini Kolaba, Bombay. Dr. Sergeant Commander Kaushik, please.
So thank you, sir. At the outset, thank you, sir, General Kapoor, sir, and Colonel Dubey, sir. Thanks for this opportunity. I hope my screens are visible, sir.
Yeah, it is visible.
So my talk today will be on the updates on the management of.
You can make it slideshow also. I think it is.
Right, sir.
Yeah, it is. Thanks.
Thank you, sir. So my talk would be on the management of the first line biliary tract cancers in India, and by the initial talk by well-known genetic, we know that it is one of the aggressive cancers which we have, and we have the major burden from the Southeast Asian countries that do from our part, UP Western Belt or Assam and Delhi part. And recently, the National Cancer Registry, based on the Global Fund 2020 data, we have around 31,000 cases reported of GB cancers, particularly in our belt per se. And majority are presented in advanced stage, either inoperable, majorly presenting either surgical obstructive jaundice. So 90% are inoperable or advanced stage, which we see in our routine OPD cases. And uh, if not treated, the median survival is just hardly less than 3 months. And on treatment too, with the current standard of care, that is gemcitabine and cisplatin combination chemotherapy, the median survival rarely reaches around a year. And 5-year overall survival is very dismal, less than 10%. And the data, it has been seen that overall in the last decade, it has been there is an increase in the incidence of biliary tract cancer, both sexes over the years. So what do we have and how do we have evolved from the management of biliary tract cancer? So it was in 2010 where the landmark ABC data, based on this data, the standard of regimen changed from single agent gemcitabine to the combination chemotherapy of gemcitabine in combination with cisplatin, where ahead on the ABC02 trial, the median overall survival has improved from 8 months to 11.7 months, hardly around 3 months improvement when combination chemotherapy was used compared to single agent gemcitabine. Also, there was a small improvement in the PFS from 5 months to 8 months, and from that decade onwards, the gemcitabine combination has been a standard of care in the management of advanced or unresectable biliary tract cancer. Followed by that, we had other non-inferiority trials of GEMOX, GEMCAP, and this is the data from the TMS group by Dr. Anant et al., where GEMOX was seen as non-inferior compared to the overall response rate of the EFS or the OS, fairly as comparable with the standard of care gemcitabine and cisplatin. And also we had another GEMOX regimen for this unresectable biliary tract cancer. Basically, the points favoring towards the gemcitabine cisplatin combination was mainly the lower incidence of peripheral neuropathy and hepatotoxicity, and the point favoring compared to the toxicity profile towards the GEMOX combination was ease of administration and also lower incidence of hematological toxicity, which is seen in GEMOX regimen. So, not fair much of options we had, but GEMCIS, GEMOX, GEMK, or else the single agent combination or non-gemcitabine based combination. So this was the standard NCCN guidelines which used to see 2 years back. The category 1 recommendation was only with the GEMCIS and all other remaining category 2A or category 2B recommendations. Then we had the era of immunotherapy, and we have seen the advances of immunotherapy in the biliary tract cancer group, and this was the Topaz 1 data which we had. It was a phase 3 randomized double-blind trial in which multinational study where unresectable biliary tract cancers were compared, gemcitabine and cisplatin was compared with the combination of durvalumab. Here the inclusion criteria was locally advanced biliary tract cancer. They included both all three, intrahepatic, extrahepatic, and gallbladder cancers, and also those who had recurrence after 6 months of curative surgery or after last dose of adjuvant therapy. Bilirubin, they want have normal, all the inclusion criteria with less than 2, and TS inclusion criteria was 0 to 1. The ample of water cancer was excluded. In the initial ABC02 study, there were few and 10% of patients who had ample of water cancer also included. Over here, they had excluded the cancer of ample of water. So randomization of 1:1 randomization and approx 350 patients in each group, durvalumab plus combination chemoimmunotherapy or the standard of care chemotherapy of gemcitabine cisplatin in the standard dose up to 8 cycles. In those who had received combination chemoimmunotherapy, after the initial 8 cycles, they were just maintained on durvalumab until progression of the disease. The major primary endpoint of the study was overall survival, and the key secondary endpoint was progression-free survival, overall response rate, and duration of response, along with patient-reported outcomes, including safety and pharmacokinetic data. Baseline characteristics were comparable in both the groups, and what we have important is one is the Asian representation. We know we are the major contributors of the gallbladder cancers. So Asian population had represented to the tune of 50% plus in this study. Asia contributing and rest of Asia is up to 52% in both the groups. And the tumor-wise, intrahepatic cholangiocarcinoma majorly contributing to up to the tune of 50-55%, and gallbladder cancer to the tune of only 1/4, that is around 20-25% in both the groups. So majorly were metastatic upfront, around 88% being metastatic. Again, equally, the MSI stable status was to the tune of around 50% in both the groups, and non-viral etiology was around to the tune of 50% plus. They had the PD-L1 expression, what we call as a tumor antigen positive subgroup. Again, it was equally divided. Tumor antigen positivity more than 1% was seen in around 55-60% in both the groups. So, as per the data cover of what we had, the patient who had received the completed treatment, initial treatment was to the tune of 99% in the group, and ongoing treatment, the data cutoff after around 2 months, after 2 years, sorry, it was around 18% in the chemoimmunotherapy group compared to only 6% in the chemotherapy group. Major reason of discontinuation on the both groups were disease progression, and those who had disease progression, around 50% received the subsequent therapy, and those around 40% was chemotherapy, either a single agent or a combination one. So this was the updated data what we have, which was presented in the ESMO 2022, the 24 months follow-up, 2 years follow-up. Here it was seen that the median overall survival with the combination chemoimmunotherapy, durvalumab along with the gemcitabine combination had improved median overall survival from 11.3 months to the 12.9 months with the hazard of 0.76. You can see with the Kaplan-Meier at the 12-month, 24-month follow-up, around 11% was the patients in the gemcitabine group were 11% compared to almost 1/4 of the patients who are still achieving the results, around 23% who are maintaining the results in chemoimmunotherapy subgroup. And the subgroup analysis revealed almost entire across all substance of the study. It was the results were favoring the chemoimmunotherapy. Either it could be the PD-L1 expression or the anatomical side. So the representation from the gallbladder cancer was to the lower side, only 88 patients in both the group, and you can see the confidence interval crossing across 1. Otherwise, in the intrahepatic cholangiocarcinoma, which was the major contributor, around 180 patients, there was seen improvement with the addition of chemoimmunotherapy. And both the Asian and non-Asian, or even the performance status also. In this study, major around 80% patients were in the ECOG PS0, which is hardly to get in our day-to-day practice. So the best benefit was seen across all the subgroups which was analyzed. And coming to PFS, there was a PFS benefit too with this combination chemoimmunotherapy. It was increased from 5.7 months in the standard of care gemcitabine cisplatin and compared to around 7.2 months in the combination chemoimmunotherapy group. You can see the 12-month PFS. It was 16% in the group which received the chemoimmunotherapy, durvalumab and gemcitabine cisplatin, to only 6% in a group with only chemotherapy. Again, the PFS benefit across all the subgroups, whether it's the PD-L1 expression or the tumor side, it was all favorably improved with the usage of chemoimmunotherapy combination. Overall response rate, yes, again it was increased. It was 18% in the chemotherapy group. It was increased to 24% in the combination chemoimmunotherapy subgroup. Also, the disease control rate was also increased. The more than 12-month disease control rate was to the 26 months. The disease control, 26% of patients who had disease control rate for more than 12 months in the durvalumab and gemcitabine combination, compared to only 15% in the placebo and gemcitabine combination. Another secondary point, the duration of response. The median duration of response was maintained. So you can see at the cutoff around 1 year, that was 15% of the patients who are remaining showing response towards the chemotherapy. However, in the chemoimmunotherapy combination, almost 1/4 of the patients who were enrolled in trial, up to 26% of patients, they were maintaining response and they were getting the results of the patient. The median time for response was shorter in the chemoimmunotherapy, was around 1.6 months in the chemoimmunotherapy combination group versus only 2 to 7 months in the gemcitabine cisplatin combination. Another interesting slide, it was those who had responded. It was in this dissected slide, it's a bit of a busy slide. We have seen that those who had responded, they continue to respond even better. In the top two the arrows in this Kaplan-Meier, if you see the purple and the yellow one, the purple was those who had responded in the chemoimmunotherapy and the only chemotherapy subgroup. The purple group, after around 12 months of the response, either the partial response or the complete response, so we can see the graph separating from them. So the response was sustained even after 12 months to 15 months of therapy with this group. And also in those with stable disease who are achieved either with the chemotherapy or combination chemotherapy, and after 6 months of the initial study, they also there was we can see the starting of the gradual separation of the Kaplan-Meier graph. So overall, those who have responded continue to respond better and they continued their response beyond the 2 years from the enrolling of the study. Adverse events, no major toxicity, chemotherapy toxicity was the standard one. Adverse events for the whole study group was the tune of 99% as expected with these two chemotherapy regimen. However, no adverse event you can see down below, any leading to discontinuation in the chemoimmunotherapy combination group was around 9% compared to around 11% in only the chemotherapy arm, and any grade events of was around only 2% in the combination chemotherapy arm compared to only 1.5% in the chemotherapy arm. Majority of the adverse events were majority chemo related and easily manageable. As expected, major adverse events were myelosuppression, neutropenia, anemia, managed easily with transfusions and supportive care, GI toxicities, fatigue, vomiting, decreased appetite, fairly manageable, and no major of grade 3, grade 4 adverse events. Majority were in grade 1, grade 2, and fairly manageable. Coming to the toxicity profile of the immunotherapy, by now everyone are quite experienced with the use of immunotherapy, and the toxicities what we had with the immunotherapy too was quite manageable. Majority in this study, the Topaz one had hypothyroidism in around to the tune of 6% of patients. That too in grade 1 and grade 2, manageable with allotoxin replacement. Other than that, it was fatigue, rash, diarrhea, fair bit, and fair bit of pneumonitis. Everything was grade 1 and grade 2, and more than grade 3 toxicities was only 2% in this chemotherapy combination group. So they also had dissected those who had experienced the immune-related adverse event, whether the OS was any difference in those patients who had or who had not had any experience of the immune-mediated events. It was seen that this combination of the durvalumab gemcitabine was associated with the OS benefit, irrespective of whether there was any occurrence of immune-mediated adverse event or not. The OS benefit was maintained in both the subgroup of population who had this adverse event profile. So based on these 2001 data, then this is the present NCCN guidelines. We can see where we have the category 1 recommendation of chemoimmunotherapy combination. Here we have gemcitabine cisplatin along with durvalumab in category 1 recommendation, along with the previous standard of care for the last almost 1.5 decade, that is gemcitabine cisplatin. So presently, with this, we have one more armamentarium in the management of biliary tract cancer, and durvalumab has seen their category 1 recommendation in the primarily unresectable or metastatic biliary tract cancer. So this era, the evolving era of immunotherapy, we have option of offering the patient with immunotherapy. Though we know it is the result what we have achieved is not that great, but still we have something extra to hope. Those who don't have any target therapy or no any precision therapy, we have this immunotherapy to be offered in this set of patients based on this data. So overall, just concluding, we can say that durvalumab plus gemcitabine cisplatin combination demonstrated statistically significant and meaningful prolonged overall survival as compared to the previous standard of care only chemotherapy, which is gemcitabine cisplatin, and it was effective across all the molecular landscape of biliary tract cancer, and those with targetable genomic alterations do derive benefit with durvalumab and gemcitabine cisplatin combination. Toxicity-wise, there was no major add-up toxicity, and it was fairly manageable, both the chemotherapy and immunotherapy combination. Presently, they have the DGCA approval for India also for combination of chemoimmunotherapy combination for this durvalumab. So based on this, the Topaz phase 3 data, it is a positive result of adding immunotherapy with chemotherapy in the first-line treatment of advanced biliary tract cancer, and can be taken as one more armamentarium in the management of biliary tract cancers. Thank you, sir.
Thank you, Kaushik. Very nicely presented the data. just tell me one thing. Is there any special biomarker which one must consider while using durvalumab, or whether in some subset of patients, any specific biomarker or molecular testing which may tell you durvalumab will better work in such subset of patients?
So presently with the data what we had received with this data Topaz 1 and also with the Keynote 1, the response seen with immunotherapy was irrespective of the PD-L1 expression, whether it's a PD-L1 high tumors or in particular Topaz trial they had analyzed the PD-L1 based on the tumor antigen positivity score more than 1% less percent. But the results were equally in both patients. Though we know that both patients with PD-L1 positive do respond very well, but I think we can offer everyone. So usually we don't do go ahead with the MSI or the PD-L1 status because we can offer them the immunotherapy for all both the set of patients. But definitely,
Whether somebody is doing some study on such type of patients, doing NGS, doing PD-L1 and trying durvalumab in such patient and finding whether it is more effective or not. I don't think so.
sir,
Any idea?
NGS we are doing the NGS we are doing was one of our AFMRC project. We are doing it up, but for the comprehensive genomic profile we are doing it up, sir. Not for particularly PD-L1 positive and negative, and then we are dividing with the immunotherapy plus and minus. But as a comprehensive profile, definitely yes, sir. As ma'am had presented, that's the way to go ahead in this biliary tract cancer, I guess.
Yeah,
So
Dubey,
with your,
any
sir,
comment? Yeah.
sir, one question, sir, with your permission to Kaushik.
Yeah.
Kaushik, most of the patient presents with jaundice, and we keep doing multiple palliative procedures, either ERCP or PTBD. So what is first question? What is your cutoff for starting the systemic therapy? Till what level the bilirubin should fall before you start? Because the data is of that serum bilirubin should be less than 2 milligram per deciliter. Secondly, we get more of gallbladder cancer where the hazard ratio in this trial is 0.90. Are you so confident to use durvalumab, that to a costly drug, with chemotherapy in our country? Although you are from a government setting, but still an opinion at your end.
Sir, taking your first question, definitely whenever the patient we have an advanced or unresectable GBC, and the major presentations are with obstructive jaundice. The first emphasis what we have is for the biliary diversion. We do make an attempt to have a biliary diversion and bring the bilirubin down. And starting threshold for starting a palliative therapy, we do keep it low. Once we have cleared of them of any cholangitis or perisepsis or infection per se, we do start with single agent per se gemcitabine. We do start in our practice, in clinical practice, we start with even with the bilirubin 5-6, we do start with gemcitabine single agent in a reduced dose. And once we have this biliary diversion and gradually the bilirubin level coming down, we add up second agent. This is what we follow in, else we have a 5FU based agent if possible. And coming to the second question, sir, we know the representative of the gallbladder cancer is not much in this clinical data. It is only hardly 15-20% representation. Majority of these data are driven by the cholangiocarcinoma. But still, we don't have anything more to offer. So I think what the current practice should be is on all the gallbladder cancer, they have to undergo the comprehensive genomic profile. HER2 positivity is seen up to the tune of 5 to 10%. So if we are able to pick up some HER2 positive, we can manage them with the HER2 targeted therapies along with added chemotherapy. Else, if you have to offer them anything other than the chemotherapy, it could be the immunotherapy combination. And again, there is a way to go ahead with the low dose immunotherapy that we are practicing in our center. So I know it is very difficult for that ASA2 people to digest, but still, low dose chemotherapy is a way to go. If we have seen in the last slide, someone who are responding, they do respond very well. So we have to just pick up those responding populations.
Kapoor sir, I would like to hear add that they are doing a lot of work on low dose immunotherapy. They are giving every immunotherapy at a low dose. And that's a very good thing.
The low dose. I do use nivolumab in the low dose. 40 milligram do use in head and neck cancer, and I find some response in it. Of course,
it is there.
Of course, I have used NR2 100 milligram also and found the response. Recommended dose is 400 milligram. But yeah, if the patient is unaffordable, probably we can give the benefit whatever with the low dose immunotherapy.
Right.
Thank you, sir.
Thank you, Kaushik.
Thank you.
Very nice talk. And now we will move on to the next talk, and it is on real world evidence of durvalumab plus Gemcis in advanced biliary tract cancer. And I do invite Dr. Satya Sadan Sarangi for his talk. He is a consultant in BLK Max, Delhi, and he will be speaking on real world data. Dr. Satya, please.
Good evening, all. Am I audible?
Yeah, you are audible.
Thank you, sir. First of all, at the outset, I would like to thank respected Dr. B.N. Kapoor, sir, and AP Dubey, sir, for giving me this opportunity to be part of this academic program. And the topic that is allotted to me is the real-world evidence of durvalumab plus chemotherapy in the biliary tract cancer. So just let me know if my slides are moving.
Yeah, it is moving.
Okay. So why the real-world evidence is important? Because we have seen many times the results that we get from randomized trials are not exactly replicated in our day-to-day clinical practice. During my DM training, I remember one of my professor saying that in randomized trials, they are the Olympic doctors treating Olympic patients with Olympic nursing staff. But in real world scenario, we hardly get this type of logistical support or patient profile also where there is a PS1 or PS0, but in real world scenarios, we have seen the biliary tract malignancy patients tend to be at PS2, sometimes PS3 also. So we'll see how this regimen, the Topaz 1 regimen, is doing in a real world setting. So the first study is from Italy, which is an early exploratory analysis of Durva plus Gemcis in the advanced biliary tract cancer setting. So for this trial, they have included 145 patients. And here, if you see, the primary tumor site was predominantly intrahepatic and the gallbladder were only comprising of 15% only. One third of patients had underwent previous surgery and one third patients needed drainage or stent placement. And if you see the liver enzymes, almost 40% means out of every 5 patients, 2 patients had a deranged liver enzyme. And if you see the median PFS and OS of this patient population, it is almost somewhat similar to the Topaz 1 trial with a median OS of 12.9 months and a median PFS of 8.9 months. So even in this Italian study, they saw that when they added durvalumab over the standard chemo regimen, there was an increase in response rate also. And it was of the order of close to 30%, and predominantly were the partial responses. And less than 5% of patients had some complete response also. Now coming to the safety and tolerability. So if you see, if you take into consideration any adverse event, then it is mostly due to the chemotherapy and less contributory due to the immunotherapy. Because if you see the immune-mediated adverse event, if you take the all grades, then it is 22%, whereas the clinically significant immune side effects are less, which is 2.1%. And this is also similar to the Topaz 1 trial. Now, coming to the real world evidence from India, because we know in the Italian study, the predominant were intrahepatic, but in our situation, intrahepatic is not the most common biliary tract cancer. It is the gallbladder cancer, which is the most notorious of them all. So there is this study from Mudu et al. And this is the real world study of Durva and chemotherapy in Indian patient with advanced biliary tract cancer. And if you see, the participating centers were from almost all the corners of the country. They have the northern population, western population, some patients from down south, as well as from the eastern part of India. So they basically are comprising the entire Indian subcontinent population. Now, in this study, they have included 75 patients from Feb 2022 to January 23 with a median age of 60 years, predominantly were male. And here, if you see the disease site distribution, the GB cancers, as expected, is the most common with a 60% incidence and followed by the 34% of intrahepatic cholangiocarcinoma. Now coming to the treatment characteristics, the median follow-up is close to 5 months, and the median cycles of Durva that was given is 4 cycles. Median cycles of chemotherapy was 5, and out of the 75, 42 patients had progressed. 26 uh, died, and the major reasons for the death is the 3 quarters. In the 3 quarters of the patient who died is because of the disease progression, and the treatment related were close to 10%. Now, if you see the overall survival data, first on the right side, if you see the for the all the entire population, the overall survival was 9.7 months. It is numerically lesser than the Topaz 1 study. And if you see, as per like the disease site specific wise, like if it is gallbladder cancer, it is further low. It is 8.4 months, and for cholangiocarcinoma, it is 14.2 months. Which we know also that GB are poor prognosis patients than intrahepatic cholangiocarcinoma. Similarly, for PFS also, it was slightly on the lower side as compared to Topaz. It is 6.1 months, and for GB, here again the same thing is reflecting. It is 1 month shorter than the cholangiocarcinoma for the gallbladder cancer patients. Now coming to the toxicity profile. So chemotherapy dose reduction was required in 18 patients. Durvalumab discontinuation was needed in 6.7% of patients. And regarding the grade 3-4 IREs, it is seen in 10 patients. And the most common immune therapy related side effect that we see was the hypothyroidism and the skin toxicity. Again, similar to the Topaz 1 toxicity profile that the previous speaker elucidated. So the conclusion from the real world experiences is the first two reported real world study of Durva and chemo from India and Italy. There is a significant proportion of GB malignancy and patient with performance status 2 in our from our Indian subcontinent. However, the PFS, OS, and response rates, they were comparable, but yes, slightly on the lower side for the gallbladder cancer patients. So the reason what they have told is that it could be because of the greater number of GB cancer patients being included. And obviously, in our setting, we have seen that once a biliary tract cancer patient progresses, they are hardly in a state to receive, or there is also lack of availability of good second line targeted therapies. So as far as the safety concerns are there, it is almost on the similar lines with no new safety signals. And it seems to be a safe and efficacious regimen for biliary tract cancers as a whole. So I think this has already been told by the previous speaker that Durva has been given a category 1 recommendation for unresectable and metastatic biliary tract cancer along with the standard GEMSIS. So if you see there is a statistically significant and clinically meaningful prolonged OS with Durva plus GEMSIS over the GEMSIS alone in both the phase 3 as well as in the real world studies. Safety wise, it is similar. There is no new safety signals. Predominant toxicity were because of the chemotherapy agents. For as far as the biomarker status is concerned, it appeared to be effective across the molecular landscape. We have the DGCI approval also for the Infinity 1500 milligram in combination with the chemotherapy, which is approved. And so that's it from my side. Thank you.
Yeah, thank you, Satya. Very nicely presented. Whatever is in the research, real world data also suggests, yes, there is a improvement in the survival with addition of durvalumab. Thank you, Satya.
Sir,
To comment?
sir, one question, sir, with your permission. Dr. Satya, a good talk. I would like to ask that because most of the patient will present with jaundice, and that is sometimes it becomes very difficult for us to bring down the level to less than 2 or 3 or 4, where we could start the gemcitabine-based regime. So because durvalumab can be given 2 weekly, 3 weekly, as well as 4 weekly. So would you be prompted to initiate durvalumab along with non-gemcitabine-based therapies? Because when patient with persistent jaundice, it is recommended that you go ahead with non-gemcitabine based chemo regimens. Would you be prompted to give durvalumab along with like modified FOLFOX every 2 weekly?
Yes, sir. I agree with your approach. Like if even after doing all the stenting and drainage procedure, if it is not possible to bring down the bilirubin levels, then obviously we need so basically we need at that point of time for that patient, we need an increased response rate, which may be there with the addition of immunotherapy. And we know that yes, immunotherapy you can start, but you have to closely monitor that if the hepatotoxicity is increasing during the immunotherapy, then you have to omit that. But yes, there is no absolute contraindication that if the bilirubin is high, that you cannot start with immunotherapy. And I agree with your approach. I would like to go with a modified Folfox plus durvalumab based regimen.
Thank you.
Thank you, Satya. And we'll move on to the next talk. And next talk is on urothelial cancer, recent advances and evolution in the management of advanced urothelial cancer. The presentation will be done by Dr. Dipen Bhua. He is the Associate Medical Consultant at RGCI, Delhi. Dr. Dipen, please.
Good evening, all. I am Dr. Deepan Bua. Thank you, organizers Dr. Kapoor sir and Dr. AP Dubey sir for giving me opportunity and to discuss the evolution in advanced urothelial treatment, urothelial cancer treatment to achieve a maximal survival benefit in a patient. Slides are provided by the Merck, and session is also sponsored by the Merck. I request organizer to share the slides for me for the presentation.
So
Next slide.
I'm already presenting the slide here.
Okay, thank you. Next slide. So we all know India a high burden of a bladder cancer, and it is common to have a late presentation in our country because of the lack of awareness and other factors that delayed medical attention seek. Bladder cancer, urinary bladder, highest incidence of urinary bladder cancer in the world is dominated by the China and USA. Nearly 80,000 cases per year reported, and India is currently listed on sixth position, 21,000 cases each year. And incidence wise, all over cancer, India is the 17th common cancer, and mortality wise is the 21st cause of death, cancer death. In comparison to US, where 5% cases reported as a distant metastatic stage for cancer, India, it is a 17% of cases of urinary bladder cancer reported with the metastatic disease. Next slide. So the evolving landscape of urothelial cancer, in which stage today we'll discuss a stage for cancer approach, in which the cisplatin was the most active chemotherapeutic agent, was noted in 1980s. Subsequently, combo based on a cisplatin was found to be more effective than the cisplatin alone in 1992. Since then, there was no developments for 25 years. Then after again, as a single agent pembro, who patients were so frequently platinum ineligible, in which the single agent pembrolizumab IO came into the picture, and it was a report. It was approved by US FDA in 2017. Then after subsequently 3 major practice-changing trial and subsequently approval of the IO and ADCs into the urothelial cancer treatment. That is the maintenance avelumab after induction platinum-based chemotherapy in 2020, and another along with the chemotherapy IO, that is the nivolumab, followed by the nivolumab maintenance. A CheckMate 901 has also approved in a urothelial cancer, and followed by EVIS 302, that is the ADC, enfortumab vedotin, along with the IO, followed by the pembro maintenance, is approved in a urothelial cancer treatment. Next slide. As we all know, in a stage 4 disease, advanced urothelial cancer, a first-line treatment is a platinum-based chemotherapy, 2 regimens, gemcitabine and platinum, or MVAC. Or reported in all studies or literature, response rate varies between 65 to 80% nearly as the first line. Next slide. In a treatment portfolio, first thing is need to be identified that whether the patient is cisplatin eligible or not. By the European Association of Urology, 2022 has given a guideline that If patient has ECOG PS 01, NYHA less than 3, EGFR more than 50 to 60, and less than grade 1 grade 2 hearing loss and peripheral neuropathy less than grade 2 is eligible, categorized as a cisplatin eligible. Another term is platinum eligible, carboplatin eligible, though cisplatin ineligible, is ECOG PS2 and EGFR less than 30 to 60. Less than 30 is platinum ineligible. Next slide. Why it is so important that in advanced urothelial cancer to give a aggressive, important, optimize the therapy, because in all new diagnosed metastatic urothelial cancer, out of that only one three-fourths of patients receive the eligible for the therapy or receives the therapy, first line therapy, out of which only one-third receives the second line therapy. So it is very important to treat with the optimizing the first line therapy in a treatment of urothelial cancer. Next slide. So which are the strategies to increase the survival in metastatic urothelial cancer? Next slide. So, first thing, as we'll discuss, carboplatin eligible or cisplatin eligible need to be categorized separately. First, traditional and old approach was wait and watch. After induction chemotherapy of cisplatin-based or platinum-based chemotherapy, the approach was wait and watch. When the disease progress, to start with the second line or platinum rechallenge. Second approach is the continuous maintenance. Start along with the chemotherapy, start IO drugs and followed by the after completion of 4 to 6 cycle of chemotherapy, induction chemotherapy, response, disease control is there, then continue as IO as a maintenance, and third is the switch maintenance. After induction chemotherapy, if response is there, switch to another agent, that is the IO drug. Next slide. So this what I discussed. Next slide. So ultimately, urothelial cancer is a chemosensitive tumor. First line platinum therapy is a standard of care, produces a good response, but these response are not so much durable. These response are short lived. Based on that, if we opt a wait and watch policy after a first line chemotherapy, the platinum based chemotherapy, the OS is limited by the chemo resistance, and in hardly 30 to 50 months of OS is there with the wait and watch approach. Next slide. In a second approach, to maximize this, if incorporation of IO along with the first line chemotherapy and followed by maintenance, what this produce? So some effort has been made via IM Vigor 130, where atezolizumab was combined with the platinum-based chemotherapy. Keynote 361, pembrolizumab was combined with the platinum-based chemotherapy, and Danube chemotherapy study, and IO plus IO. Durvalumab and tremelimumab was given and followed by the maintenance, and LIFT trial, where IO and TKI, pembro and lenvatinib was started and followed by maintenance. All were negative. None of the trial was positive to favor maintenance of IO followed by induction. Next slide. Third approach is a switch maintenance. Following the chemotherapy, avelumab and pembrolizumab were studied. Javelin bladder 100, which is a phase 3 trial, we'll discussing in next few slides, in which chemotherapy followed by IO maintenance showed significant benefit in OS and as well as the PFS in advanced urothelial cancers, whereas the pembrolizumab has failed to show any benefit. Next slide. What is the rationale for this approach, that for chemotherapy followed by the avelumab maintenance in metastatic urothelial cancer? It is basically a chemotherapy which decreases the tumor burden to achieve disease control and increase the immunogenicity of the tumor microenvironment so that avelumab can work and effective. This is the rationale which was given to switch for the switch maintenance. Next slide. This is the Javelin bladder 100, in which after a standard of care, if disease control, radiological CR, PR or stable disease, patient was randomized into the avelumab with the best supportive treatment and the best supportive care alone, in which the inclusion criteria was given was the unresectable locally advanced urothelial or metastatic urothelial cancer with a miserable stage 4 disease, and 6 cycle. In platinum, both cisplatin and carboplatin along with the gemcitabine was allowed after a treatment-free interval of 4 to 10 weeks after induction chemo. Based on the disease response, CRPR, after in patients which are responding, in which avelumab 10 milligram kg 2 weekly till disease progression or unacceptable toxicity was permitted. Stratification was CRPR or stable disease or metastatic site, that is visceral or non-visceral. And primary endpoint was OS, and primary analysis population was all patient and PDL1 positive population. Secondary endpoints were PFS, OR, time to response duration, disease control, and safety and patient-related reported outcomes. Next slide. Baseline characteristics were median age of 68, and males were 76%, females were 24%, echo PS 0 and 1. On local and visceral and non-visceral metastatic disease was 45 to 55%, and most of the patient has received the gemcitabine with cisplatin, followed by gemcitabine with carboplatin 52 and 42%, and 6% have either of these. Next slide. This is the median overall updated survival, which was discussed in ESCO GU2 2023, in which avelumab, maintenance avelumab arm provided the overall survival of nearly 30 months compared to best supportive care in 20 months, with the delta of 9.2 months, improvement of survival 9.2 months, with hazard ratio 0.77, 23% reduction in risk of death. Next slide. PFS, median PFS was also in avelumab arm was 5.5 versus 2.1, with a hazard ratio for 0.54. That is a reduction in 46% in a disease risk or a death, disease progression or a death. Next slide. Subgroup analysis, subset of a patient from a Asian community, 21% were overall population from a Asian community, and similar benefit was replicated in that also. Next slide. Nearly OS, nearly 29 versus 18, and PFS also 5.6 versus 1.9, with significant hazard ratio and P value. Next slide. So OS benefit was in overall OS and PFS benefit was given in overall population as well as the Asian. In subsequently subgroup, whether any chemotherapy difference, whether cisplatin or carboplatin makes a difference. So this study has shown that in a cisplatin, it doesn't affect the outcome. That is a cisplatin or carboplatin, whether carboplatin or cisplatin, in both the population had shown that the prolongation of OS as well as the PFS. Next slide. Now, real world comparison. We had discussed the Javelin Bladder 100. Real world comparison with the avelumab maintenance, real world evidence as well as the READY multi-center Italian study also reported the same benefit in a 12-month OS rate, that is a 71 in Javelin Bladder 100 compared to that in evidence 65 and 69 in READY. And PFS also comparable in 5.5, 5.7 and 8.1 respectively. Next slide. So after the progression on the maintenance avelumab, how would you sequence the line for the first subsequent line? This study has also given us some insight in that. Next slide. Next slide. In a patient who has a total randomized in avelumab with the best supportive care arm was 350, and still receiving was 43 patients, and discontinued due to progression or the intolerable toxicity, a total 307 patients. And among that, 122 not received any treatment, and those out of that 185 who received a second line treatment, in which after adequate platinum based chemotherapy period, that is a 12-month, rechallenge with the same platinum based chemotherapy, Those who are PDL1 treated, 8-9 treated with the Pembro, 1 received Atezo and 1 received Nivolumab, and other chemotherapeutic agents as well as the targeted agents as well as the ADC. In 99 patient, the patient has received. Next slide. This was the abstract was discussed in ESCO 2024 regarding the histological subtypes and the long-term outcomes from the Javelin Bladder 100 trial, that is avelumab maintenance. Next slide. And results of that that was is that histological patient have a urothelial cancer mixed with the other histological subtypes less than 50%, predominant urothelial cancer. OS rate remain OS benefit is remained with the avelumab. That is the first year 71%, 71 versus 58, 2 years for 43 versus 40, and 3 years 37 versus 31. Next slide.
Hello, sir. I request you to conclude your slides in next 2 minutes.
Yes, next slide. This is also PFS benefit across the various histological subtypes predominant by US. Next slide. UC, sorry. Next slide. And the low tumor burden, according to this was another abstract was discussed in the ESCO 2024. Next slide. That summarized that the non-visceral metastasis, lymph node only disease and retroperitoneal only disease have a OS better with the avelumab. Next slide. Next slide. Next slide. Next slide. This was regarding the checkmate 901, that is the nivolumab along with the gemcitabine and cisplatin with the comparator chemotherapy gemcitabine and cisplatin. In this inclusion criteria, only cisplatin eligible patients were there. In after the 4 to 6 cycles of chemotherapy followed by the nivolumab maintenance. Next slide. In which PFS benefit was there. Next slide. Though the PFS benefit was there, was the marginal. Previous slide, please. Marginally, only 9 days PFS benefit was after a 7-month treatment. Next slide. And the OS 70 versus first year OS 70 versus 62, and the 2 year 2 year PF OS was 46 versus 40. So the marginal benefit with the addition of the nivo in chemotherapy followed by maintenance. Next slide. Next slide. Next slide. And third important trial is the EV302 trial, in which the standard of care chemotherapy or compared with the that one investigation arm, that is the enfortumab vedotin, that is the ADC with the pembrolizumab in number of chemotherapy treatment cycle. EV was given for the 7 to 9 cycles followed by the pembrolizumab maintenance, in which the eligibility criteria, platinum eligibility, if the any carboplatin or cisplatin were eligible, untreated advanced urothelial cancer, PD-1 inhibitor naive, and EGFR more than 30, ECOG PS less than 2, and dual primary endpoint were PFS by the blinded independent central review and OS, and select secondary endpoints were response rate as per the RECIST and safety. Next slide. That showed this regime has a remarkable improvement in the OS compared to that 31 compared to 16, with the significant hazard ratio 47. Next slide. And as this response is miraculous, this comes as a post hoc side effects, 3 to 4 times highly toxic regimen with the significant peripheral neuropathy, ocular, and the alopecia. Next slide. Another real-world study which was discussed in ESCO GU24 based on the avelumab first-line maintenance, how to sequence the agents following the avelumab maintenance in urothelial cancer. Next slide. In which, after the platinum-based chemotherapy in first line and avelumab maintenance, second line ADC, what is the outcome? So, in which the after OS, at the 1 year OS, 96% patient were allowed. At the 2 years, 81, and 3 in subsequently 3 years, nearly 55 to 60% patient were alive. Median OS was 40.8 months. Next slide. So overall survival, if we put the all agents and the sequence together in checkmate 901 with that approach, median survival is 21 months. Javelin bladder all patient, median survival is nearly 30 months, and in cisplatin treated patient 31. In EV302, that is 31.5 months, and evidence the real world platinum-based chemotherapy followed by the avelumab maintenance followed by ADC and followed by subsequent agents produces the miraculous 40.8 months survival. So it is important to sequence that is the treatment agents and the treatment landscape. So we can give a maximum benefit to our patients. Next slide. So treatment landscape of the metastatic urothelial cancer is evolving. Maintenance avelumab significantly increases the survival nearly at 30 months, but OS benefit of a maintenance this benefit was irrespective of the chemotherapy regimen, duration of the chemo, and response to first line chemo. Though as per the checkmate 901, Nivo plus gemcitabine and cisplatin is a positive study, but the benefit is very dismal in PFS and OS. Pembro and enfortumab vedotin data looks promising, but needs to be very cautious regarding the toxicity profile, as the skin, ocular, and neuropathy is significantly high and 5 times more toxic than the standard of care arm. And finally, as the result of the Evidence trial study, subsequent availability of an option is a key. First line chemotherapy followed by avelumab followed by the ADCs produces the 40.8 month benefits, so which one should not neglect. Next slide. Thank you.
Thank you, Deepan. You have covered urothelial cancer very nicely in the metastatic setting. Nice presentation, but extensive. And I think we are short of time. So we will skip the question answer and we'll move on to the next talk. Thank you, Deepan. Thank you.
Thank you, sir.
And I do invite Dr. A.P. Dubey for his talk on evidence of use of atezolizumab plus bevacizumab in unresectable hepatocellular carcinoma. Dr. Dubey, please.
Sir.
Dr. Dubey is, everybody knows him, so I don't introduce him. He is a very well-known personality. So I will skip the introduction also. Yeah.
Good evening, sir. And it's always fortunate to speak in front of you. Since my super specialty days when I was resident in front of you making lots of mischief. So now I'm consultant, so it's okay, sir. Not introduce me. So I would like to thank B.N. Kapoor, sir, for giving me this opportunity, as well as also at the outset, I'd like to thank organizers for organizing such beautifully without any technical glitch. So I'll be speaking on real-world evidences of atezo plus bevacizumab in hepatocellular carcinoma. So as Dr. Satya has very beautifully said that why we need real-world data, because in randomized study phase 3 data, the Olympic doctors are treating Olympic patients with Olympic staff. And I concur with that, because the phase 3 data actually really does not replicate our day-to-day practice. And most of the patients we see day-to-day in our day-to-day clinical practice are generally not included in phase 3 trials, owing to their stringent inclusion as well as exclusion criteria. So here is the need of real-world data, which gives us lots of confidence for offering that particular therapy to our patient. For example, most of the phase 3 studies in oncology have excluded patients with brain metastasis, but at least 1/5 of the patients in all malignancies will present as brain metastasis. So what to do with those patients? So that confidence in professionals is built by the real world evidence or the real world data. So this is atezo plus bevacizumab data in real world setting. So first is international data, that is US plus Europe plus Asia, where total population, study population was 433, where around 130 patients were excluded owing to Child-Pugh C, and it was not first line because Child-Pugh C becomes BCLC D. And as per the phase 3 trial in BCLC D, we are not supposed to offer systemic therapy. So coming on to the right side, the baseline characteristics, here you can see that the majority of the patients were male, around more than 80%. And they were equally distributing patients in ECOG 0 as well as ECOG 1. BCLC patients were around 70%. And if you see that around two-thirds of the patients were having viral etiology, so around one-third were having non-viral, maybe NASH related, and portal vein thrombosis, that is portal vein tumor thrombosis, was present in 35% of the cases. That is because tumor thrombosis, so bevacizumab is actually can be offered in such subset of patients. So ABREL study, it has reproduced the similar profile as what we have seen in IAM-BRAVE 150, which was a phase 3 data which has addressed the role of atezo plus bevacizumab in advanced hepatocellular carcinoma. Here you can see that in ABREL, that is real world evidence, the median OS was found to be 15.74 months. And in IAM-BRAVE, it was around 19.2 months. And the median PFS was around 7 months in ABREL, and it was almost same for IAM-BRAVE, around 6.9 months. So the highlights of ABREL were that baseline characteristics as prognostic factor and association of prognostic factors with the outcome. So what were the prognostic factors or the baseline characteristics which were studied for the favorable or unfavorable outcome? One was alpha-fetoprotein, child-pugh score. That is a very prominent or the paramount baseline characteristic on which the outcome is depending upon. Portal vein tumor thrombosis, ALBI grade 1 or 2, radiological response. So highlights of ABREL was that overall response rate was around 30%. And disease control was seen in around more than three-fourths of the patient, that is 77.7%. Objective response rate is a surrogate value for survival benefit that we all agree with that. Most common treatment-related adverse event was hypertension and proteinuria. That was because of the addition of bevacizumab. We all know that bevacizumab is associated with hypertension and proteinuria, and these two adverse events should be monitored whenever we are offering bevacizumab in oncological setting. Bleeding was seen in around 8.4% patients, with esophageal varices being the most common site. So what was different from IAM-BRAVE 150? That patient with non-viral etiology had comparable outcomes as compared with viral etiology, which was not well evident in IAM-BRAVE 150. Even in Himalaya trial, which addressed the role of durvalumab plus tremelimab in advanced SCC, that also has shown the survival benefit or dual checkpoint inhibition with non-viral patient. And now, as I would like to submit here that patients with non-viral etiology coming up with chronic liver disease and hepatocellular carcinoma are quite increasing in incidence. So highlights of ABREL was the standard of care patients who mirror the IAM-BRAVE 150 inclusion criteria, eligibility for immunotherapy in advanced hepatocellular carcinoma. That was not quite universal in the real world study, and patient selection is key to optimize the outcomes. So prospectively maintain retrospective data, quality of radiological assessment and response. The overall conclusion from the ABREL, which is real-world evidence of atezo plus bevacizumab, was that it was an observational study with reproducible efficacy as well as safety and tolerability of atezo plus bevacizumab in routine clinical practice outside the phase 3 study. In other analysis, atezo plus bevacizumab has been explored as an option outside of the IAM-BRAVE setting. The combination appeared safe and effective in an older cohort of the patient with hepatocellular carcinoma, and the preliminary evidence of the combination efficacy and tolerability in patient with child-pugh B has also been reported, where the trial tend to exclude such subset of the patients. So what is the Indian real-world evidences for atezo plus bevacizumab in metastatic or unresectable hepatocellular carcinoma? So here is the Indian data. So around 67 patients with advanced hepatocellular carcinoma were treated with atezo plus bevacizumab, and the primary endpoint for to assess overall survival, progression-free survival, as well as the safety profile among the different childhood class. So these are on the left side, we can see the baseline characteristics where you can see the median age was 61 years and around 60, or around here also around near about 90% were males. And there were 1.5% patients with a history of varicose bleed. And you can see that if you talk about the etiology of the chronic liver disease, NASH accounted for around 55.2% of the cases. Whereas if you talk about the viral etiology, that was seen in around 40% of the cases. And alcohol was supposed to be in 7.5% of the cases. If you talk about childhood class A, B, and C, in C, we generally don't give systemic therapy, and supportive care remains the standard treatment plan. So here, childhood A, there are 35.8%, childhood B, 53.7%. If you talk about BCLC stage, then B, 9%, and C, around 75% of the patient, that is 50 patients. And D, there was 16.4%. There were extrahepatic spread too in the patients. And patient had underwent prior therapies too, like few patients had underwent TARE or TACE or microwave ablations for adrenal metastasis. So these are the overall survival and progression-free survival as per the child book. On left side, you can see the overall survival. You see that the patient with child book score A tend to have the maximum survival of 21 months, whereas with child book C having the survival of only 4 months. So it is not recommended to give such therapy to child book C patients. Whereas if you see progression-free survival, we get the similar trend of results. Child book A patient tend to have progression-free survival of 18 months, whereas child book C patients have 2 months only. Talking about the adverse event, because whenever we are talking about metastatic disease or the advanced disease, our aim remains to prolong the survival, but also to maintain the quality of life. So the safety profile remains paramount in all the studies and whenever we are talking or offering any drug to our patient. So if you see the adverse events, they were not quite much. And if you talk about grade 3 or more, they were just less than 15% of the patients which had grade 3 or more. And rise in serum bilirubin was the most common grade 3 adverse event which was being seen. Otherwise, they were fatigue, hypertension, fever, ascites, loss of appetite, oral ulcers, skin rash, and multiple adverse events which were even seen in the phase 3 data also. So now talking about the grade 3 events, the grade 3 event, the most common was rise in serum bilirubin. Others were fatigue, hypertension, variceal bleed, and ascites. But these adverse events tend to be higher in patients with childhood C, but they tend to be lower in patients with childhood A, and of the intermediate incidence in childhood B. So that's why it is advisable to initiate the immuno plus bevacizumab combination only in patients with childhood A and childhood B, whereas the palliative care or the best supportive care in childhood C or the BCLC-D. So summary is that selecting the right patient is key to success, because in all patients, we don't tend to get the similar benefit what we see in phase 3 data. So child book C should not be given this treatment because child book C comes in BCLC-D, and it is very much clearly mentioned in the guideline that BCLC-D should be managed with the best supportive care rather than any systemic treatment. Variceal bleeding is less than feared. Actually, whenever we are planning for atezo plus bevacizumab, patients should have underwent UGI endoscopy in last 3 to 6 months. And if the patient had varices, those varices should have been addressed. Patient with a history of variceal bleeding and portal vein tumor thrombus should be monitored cautiously, although bevacizumab can be offered to such patient also after addressing the variceal bleed. UGI endoscopy, as we are very much clear, that should be done in all patients. And whenever it is required, as per the GI physician's advice, the banding should be done. And because all the CLD, chronic liver disease, most probably they'll be associated with the portal hypertension and the esophageal varices. So other important real world evidences from the different countries, Germany, Austria, Asia, and China, you can see that the majority of the benefit is achieved by childhood A, with the median survival or progression-free survival or overall survival in the median progression-free survival of around 10 months, the overall survival of 16 to 18 months by childhood A rather than childhood B or C. So we can offer it childhood A or B, and we should avoid it childhood C. Survival is lower if atezo plus bev is used in later line. We know that hepatobiliary are aggressive malignancies, and sometimes the progression might preclude the use of atezo plus bev. And also there's data that using this combination in the later lines tends not to be as beneficial as in the upfront lines. So this is meta-analysis of systemic therapy in hepatocellular carcinoma. So efficacy and safety of atezo plus bevacizumab in advanced hepatocellular carcinoma in the real world, a single arm meta-analysis where multiple studies were combined in 3168 patients, and which have concluded very clearly that the pooled median overall survival and the median progression-free survival was 15 and 6.66 months respectively with atezo plus bevacizumab. And this combination had showed good efficacy and tolerability in the treatment of advanced SCC, and it has shown better response in the long terms in first line and standard dose treat. And it is a standard line of treatment for advanced SCC. So there's also meta-analysis too, which is network meta-analysis. Network meta-analysis is the combination of various studies where the multiple combination or multiple single drug or single agents are studied as the best effective treatment for particular malignancy. So we have network analysis for different combinations as well as the different therapies in advanced SCC from, and we can see that there were around more than 2,000 records which were first screened, then the duplicates records were removed, and then full text were separated. Then there were certain qualitative studies, then there were meta-analysis. They were then it was been found that once it was concluded, then network meta-analysis had the results in the form of that atezo plus bev has the best response in the terms of overall survival as well as progression-free survival. You can see the hazard ratio of atezo plus bev is of the tune of 0.6, 0.5, 0.4 as compared to nivo, lenvatinib, sorafenib, brivanib, or sunitinib. So best formation as of now is atezo plus bev. If that cannot be given because of contraindication to bevacizumab, one could try the single agent nivolumab, whereas we don't have the phase 3 data for nivolumab. So outcomes of the first line treatment, that overall survival benefit is best with atezo plus bevacizumab compared to the other treatment, including lenvatinib, nivolumab or sorafenib. Progression-free survival, again, atezo and bev and lenvatinib showed PFS benefit over sorafenib. And amongst ranking in network meta-analysis, atezo plus bevacizumab ranked highest in the terms of progression-free survival and overall survival, as it is evident. So this is the suggested treatment or algorithm. Patients where immunotherapy can be offered, bevacizumab can be offered, atezo plus bev remains the standard of line. If not, then TKI. This is a ranking of first line treatment. Atezo plus bev stands first with the best hazard ratio, and amongst the progression-free survival 2. This is the table showing ranking of the first line treatment. We can see that atezo plus bev has the best P-score as compared to other in the terms of overall survival as well as progression-free survival. But once if we are not able to give bevacizumab because of the multiple reasons, because of the contraindication, then we should go ahead with nivolumab, and if not, then lenvatinib. So this is to summarize my last slide, that atezo plus bevacizumab combination had shown the best benefit in the terms of overall survival and progression-free survival benefit compared with all whatever regimens, whatever combination, whatever the single agents we are having for advanced or unresectable hepatocellular carcinoma, Atezo plus bevacizumab combination is the standard of care in the first line setting in treatment with advanced hepatocellular carcinoma. We have the phase 3 data, IMBRAVE 150. We have multiple real world evidence. We have network meta-analysis. So whenever patients of advanced hepatocellular carcinoma is encountered, and if patient is fit to receive immunotherapy and bevacizumab, Atezo plus bev remains, as per guidelines, the most effective treatment. Thank you. Thank you so much.
Thank you, Dubey. Very nice presentation of use of atezolizumab and bevacizumab in HCC. What I remember is NCCN only recommend it for child A only.
Yes, sir.
In the Indian, I think the child B patients were also in a large quantity.
Yes, sir.
So-
Because in we hardly see patients coming with childhood A in hepatocellular carcinoma. But so that's why real world evidence has included actually everything, childhood A, B, and C. But the benefit is achieved by childhood A and B only. C, irrespective of the treatment,
I
is
think
very bad.
tolerability is also best with childhood A and
Right, sir.
B
Right,
and
sir.
C is not. C
Right,
is
sir.
out of question. B is also difficult to manage.
Right, sir. Right, sir. Correct.
Yeah. Thank you, Dubey. Very nice talk. And we'll move on to the next talk. And I do invite Dr. Shiva Shankar, and he will be speaking on use of anti-angiogenic therapy for progressive metastatic hepatocellular carcinoma. Dr. Shiva Shankar, please.
Thank you, sir. At the outset, I would like to thank both B.N. Kapoor sir and Dr. Dubey for providing this wonderful opportunity. And in the last session, we heard Dr. Dubey has very nicely taken through first line management of metastatic hepatocellular carcinoma. That sir has briefly, nicely touched upon what are the treatment options available in first line, both immunotherapy plus and anti-angiogenic, along with even TKS whenever they are contraindicated, and immuno plus TK as sir, immuno plus bevacizumab as sir has said that it remains standard of care. So once if they progress on the first line therapy, how do we manage these patients? Until recently, that is until few years back, it is only sorafenib which was available as a treatment option in the hepatocellular carcinoma. But if you look at NCCN, now there are so many options to choose for management of hepatocellular carcinoma. So now we have moved. Initially, when only sorafenib was available, how do we change treatment? If there is only symptomatic failure, then we used to change or stop sorafenib. Nowadays, it is not. We don't stop at symptomatic failure, but even if there is a radiological failure, then also we'll change therapy. So whenever they progress on first line therapy, we do see quite a number of patients who are fit enough to receive subsequent therapy, and the options are TKS. And if they haven't received immunotherapy in upfront, we have option of both a combination of immunotherapy, that is nivolumab plus imlumab, and our single agent immunotherapy such as pembrolizumab or nivolumab, and also we have ramucirumab. So this was the consensus which was seen with, if given an option, if there are no cost issues in particular situation, if they had not received upfront immunotherapy, and if they are child A and PS of 0, what would it be? Who have progressed on sorafenib, and many of the responders has preferred, even in those situations, though the data is for first line, as sir has said that in the later lines the benefits go down. Despite that, the immuno combination remains the top priority. If still they are contraindicated, then the TKS, regorafenib or cabozantinib or ramucirumab. However, if the patient has received upfront immunotherapy, then subsequent sequencing with immunotherapy doesn't make much sense. So in those situations, usually the other TKS like lenvatinib, ramucirumab, sorafenib, or cabozantinib. However, the limitation of the data we have for subsequent line is that majority of these trials are conducted in the era when the sorafenib was the standard of care in the first line. Now we have the standard of care is that is immunotherapy, but none of these studies have addressed how these patients who have progressed on immunotherapy plus bevacizumab, how do they fare on the subsequent therapy. But with limited data available, we need to extrapolate from the previous data, and we need to use these drugs. So the first among the subsequent line therapy is regorafenib. Regorafenib, if you look at the structure of the regorafenib, it is not very different. Just there is a addition of fluorine atom in the central phenyl. Otherwise, if you look at the whole of structure, it is same as sorafenib. But just this replacements will lead to lot of changes. It is more potent target profile than the sorafenib. It is multi-kinase like sorafenib. It acts on VEGFR receptors, c-KIT, TIE2, PDGFR beta, FGFR, RET, RAF, BRAF, and MAP kinase. Regorafenib metabolizers have continued anti-neoplastic effect during even 1 week washout. Usually we give regorafenib 3 weeks, 1 week off, but its anti-neoplastic activities persists during even the 1 week off period. So what was the trial which looked at the role of regorafenib? It is a resource trial which included hepatocellular cancer patients with a documented radiologic progression during sorafenib treatment. And they were randomized in 2:1 fashion with 160 mg, 3 week on, 1 week off versus placebo. So if you look at the primary endpoint of this trial, the overall survival, it has met its primary endpoint, that it has shown that there is a marginal benefit if we treat these patients with regorafenib rather than just continuing best supportive care. So the median OS improved from 7.8 months to 10.6 months with hazard ratio of 0.63. And we can see that suppression of curves seen quite early in the course of the disease, and also if we see even beyond 2 years, also curves keeps the suppression is present even beyond 2 years. If you look at the various parameters of this trial, median OS has improved from 7.8 to 10.6, median PFS from 1.5 to 3.1 months, median time to progression similarly 1.5 to 3.2 months, and objective response rates were 10.6 and disease control rates were 65%. In first line trial, we had seen 77%, here almost similar 65%, but response rates were only to the tune of 10%. So median OS of 26 months from first sorafenib dose to death in resource study was, if you look at in the rest of the world, it was, if you look at in the regorafenib arm, it was 99.9 versus 26.8 months. In Asia, it was 15.6 versus 21.5 months. And if you combine all patients, it was 19.2 versus 26 months. So if you look at the adverse events, as we expect with any anti-angiogenic TKI, the majority of the side effects will be either in terms of vascular events like hypertension, proteinuria, or GI symptoms like diarrhea. These are common in these with these multi-kinase inhibitors. So diarrhea was seen in roughly around 40%, and grade 3 was seen in only in 3% with regorafenib. And the hypertension was usually manageable, that is seen in 31% of the patients, and grade 3 hypertensions were seen in 15%. Apart from that, transaminitis, hypophosphatemia, and hematological side effects like anemia were also seen with regorafenib. Apart from regorafenib, we have also another multi-targeted tyrosine kinase inhibitor, that is cabozantinib. The role of cabozantinib was looked in Celestial trial. In this, again, it was compared with placebo. The time when the trial was started, there was no standard second-line treatment option. Again, in similar to resource trial, it was randomized in 2:1 fashion, either cabozantinib 60 mg once daily or placebo. All the patients should have received prior sorafenib. So again, the data is only post-sorafenib. We do not have much of data for post-immunotherapy patients. So in the Celestial, again, median OS has improved from 8 months to 10.2 months by giving cabozantinib rather than continuing just best supportive care. And if you look at the median PFS, it almost tripled from 1.9 to 5.2 months with cabozantinib. And again, the side effects profile were similar, that GI symptoms, diarrhea was the most common predominant symptom, and grade 3 were to the tune of 10%. Apart from that, palmoplantar erythrodysesthesia, which was seen similar in sorafenib group also. So the any grade my HFS was 46% and grade 3 events was 17%. Apart from that, vascular events like hypertension were also commonly seen, and transaminitis, weakness, fatigue were also commonly reported with cabozantinib. So if you look at OS and PFS benefit based on the AFP level, we can see that if AFP level, they did a various stratification, AFP less than 20, more than 20, AFP less than 200, more than 200, 200, and similarly less than 400 and more than 400. Does it make much of it? If AFP was less than 20, with the cabozantinib, the median OS was 14.4 months and median OS was 13.7 months in the placebo. So there is hardly any difference, and they tend to do similarly. Probably this is a good biology of disease, irrespective of whether we give cabozantinib or placebo, they tend to do well. However, those who had AFP more than 20, among them, the cabozantinib resulted in almost doubling of OS. Similarly, in more than 200 and also in the more than 400 group. So lower the AFP level, probably it reflects that the burden of disease and the biology of disease is probably favorable. Similarly, even in the median PFS events, we had seen that almost doubling and tripling of PFS with cabozantinib as opposed to placebo. Apart from these two drugs, that is regorafenib and cabozantinib, we also have a ramucirumab, which was tested in REACH study. And this study had basically stratified the patients into two groups. That is, one who had alpha fetoprotein more than 400 nanogram and another had alpha fetoprotein less than 400 nanogram per ml. And if you look at the patients who had alpha fetoprotein less than 400 nanogram per ml, there is hardly any difference whether they received a ramucirumab or they just received best supportive care. The median OS was similar in both the groups. However, those who had AFP more than 400 nanogram per ml, the median OS almost improved from 4.2 to 7.8 months. So ramucirumab is approved only for use in patients who have progressed on first-line TK and also have a AFP of more than 400 nanogram per ml. REACH2 study, ramucirumab patients with a previously treated HCC and higher AFP. In this, only those patients who had a AFP more than 400 mg per nanogram, which was tested in the first REACH first trial. Only those patients were included, and they were randomized into ramucirumab versus placebo, ramucirumab 8 mg per kg versus best supportive care. And if you look at the median OS, it improved from 7.3 to 8.5 months, and median PFS increased from 1.6 to 2 months with ramucirumab. Though it was shown that statistically it is significant, however, the magnitude of benefit is very small. So the pooled overall REACH2 and REACH trial, they combined the data of both REACH1 and REACH2 trial, and they included total of 316 patients. And when they included all these patients who had AFP more than 400 nanogram per ml, the benefit was further increased from 5 months to 8.1 months improvement in median OS. That is roughly around 3.1 months increment in the median OS. That's how, I mean, as Sir has also shown in the previous trial, that with the meta-analysis, we'll have a better statistical power to assess the efficacy of the given treatment. So if you look at the treatment-related adverse events, again, this is also anti-angiogenic. So the expected side effects will be mainly vascular and vascular, like hypertension, proteinuria were also seen with ramucirumab. The any grade hypertension and proteinuria were 12 and 18%, and grade 3 to grade 5 events were 13 and 2%. Apart from that, GA symptoms and fatigue, weakness, headache, constipations, pyrexia, they are also reported with ramucirumab. However, grade 3 to grade 5 events were in single digits. So to conclude, if patients has received immunotherapy upfront, then usually if the patient is fit enough and if they are child-pugh A, the subsequent options will be these TKs. But if the patient hasn't received upfront immunotherapy, then probably still they might be eligible for, not only for TKs, they also may get benefit from immunotherapy, like either combination of immunotherapy with Nivo plus CP or Pembro or Nivolumab alone, or as quoted, Atezolizumab plus Bevacizumab. And sometimes if multiple lines they have progressed, even some chemotherapy options are also available for these patients. With this, I conclude, and thank you.
Thank you, Shiva. Quite a good presentation in patients who have progressed on first line. I just a very small question. Would you like to ever re-challenge immunotherapy if patient has responded well to it in first line setting?
I mean, why would I have stopped the treatment, sir?
No, patient has progressed on first line after responding for maybe about 9 or 10 months. Then you have given a second line treatment. Then in later lines, would you ever like to re-challenge the patient with that immunotherapy drug or maybe a different class immunotherapy drug?
No, as of now, I do not think, sir. I mean, there's a data to support if they once they progressed. Had we stopped the immunotherapy for certain reasons like not cost, or if they have not they had taken for 2 years and they remain disease free, and after 1 year if they progressed after stopping the therapy, then only in those situations I would like to re-challenge, rather than those who have initially responded but progressed while on immunotherapy. I do not think as of now we have a data to support such kind of practices.
Fair, fair. Thank you, Shiv Shankar. Next, I would like to invite my very dear and guide, Dr. Sameer Khatri. Sir is quite dear to me. I have worked with sir for good about 7, 8 years. So I have learned a lot from sir. So he'll be speaking. He's presently working as director at Max Parpatganj Hospital. So he'll be speaking on reigniting the recent landscape in advanced or metastatic hepatocellular carcinoma. Over to you, sir.
Yeah, thank you, Amba. Thank you, Dr. Kapoor, for inviting me for this talk. And most of the topic has been covered. I will be quickly going through my slides. I will share my slides. So, as we have discussed that hepatocellular carcinoma, it is the third leading cause of cancer-related death worldwide. And if we see this BCLC 2022 staging and treatment algorithm, this is basically based on the tumor burden, the liver function, and the physical status, the performance status. And it is defined by the alpha-beta-protein LV score and the child book and MELD classification. And they have classified into a very early stage, the stage 0, then the early stage, that is A, and intermediate B, and at advanced stage C, and the terminal D stage. So we will be concentrating on the advanced stage, that is the stage C, which is characterized by either the portal vein invasion or extrahepatic spread, that EHS. And there is a preserved liver function with a performance status of 1 and 2. These are the patients who can undergo the systemic therapy and have a expected survival of about 2 years or so. So these are the, as I said, the systemic therapy, the survival of nearly 2 years. So these are the first line therapies available to us. And we have already discussed about these things, the Atezo-Bev or the new thing, that Durva and Tremor. And if it is not feasible or the patient cannot afford, then sorafenib or lenvatinib or single agent durvalumab in certain categories of patients. Second line, already discussed about this regorafenib, cabozantinib or amorosizumab, especially in those patients who have alpha-beta-protein of more than 400. And the third line, cabozantinib. These are the options available to us. And if you see, these are the both. This slide shows both the first line and the second line. In the red, it is the first line, that's sorafenib, lenvatinib, and now the Atezo and Bev combination. which was compared with sorafenib, and even the lenvatinib was compared with sorafenib. So these are the timeline, and in the second line or the third line therapies, we have regorafenib, cabozantinib, ramucirumab, and other ITI. But if we see this list, it is a too long a list for a negative trial. And if we talk about the molecular therapies based on for the HCC, this is a 2021 study. The phase 3 trials which have failed in the red, these are the failed trials like sorafenib, erlotinib, sorafenib, brevanib, and others. But there's the positive studies, as I have already told, is the sorafenib study, the atezo-bev study, or tremi and durvalumab. And in the second line, again, ramu, regorafenib, or cabozantinib. So lot of negative studies have been there. And these are, again, the treatment landscape on unresectable HCC. And this all started like 2007, the sorafenib, it was compared with placebo, and the median overall survival was about 3 months better than the lenvatinib and sorafenib. The reflect study, again, the survival was slightly better. And similarly, now we have this two important studies in the first line, the BEV plus atezo study, the IM-BRAVE 150 study, where the median overall survival now is as high as 19.2 months versus the 13.4 months. And the durvalumab and tremelimumab versus, again, both the studies had the sorafenib as the second arm. And in this Himalayan study also, Himalaya study, the median OS was 16.43 versus 13.7. And the second line, we have now Pembro in the keynote 394 study, and Nevo and Epi in the checkmate 040 study. So, like if we talk about sorafenib, it was in 2007, this publication was there, and the median survival was 10.7 versus the 7.9 months. And this was compared with placebo. And if we see the head-to-head, the sorafenib and lenvatinib, more or less the median overall survival is 13.6 months versus the 12.3 months. So what about this combination, the IM-BRAVE 150 study, the atezo plus BEV? It has, as already mentioned, significantly prolonged the PFS compared to atezo-BEV. This is a study, this phase 1B study of about 159, which compared these two things. And it showed that the PFS was better when the combination of VEGF inhibitor was there with IU. And the rationale of this combination we have discussed, and we all know how the cold tumor is converted to hot tumor, and that the effectiveness of this immunotherapy along with VEGF inhibitor is there. I will not going into the details of this. The same thing, this IO combination, the IO can be combined with either the VEGF inhibitor like bevacizumab or lenvatinib or cabozantinib, or it can be combined with the CTL4 like this ipilimumab and nivolumab, or the tremelimumab and durvalumab, the new study as I already discussed. So what was there in IM-BRAVE? Quickly, we all know atezo plus BEV was compared with sorafenib. And important thing is that this study included a high-risk patient, about 20%, who had main portal vein invasion, bile duct, or more than 50% of liver involvement was there. So these are the baseline characteristics. Important thing to remember is that the high-risk patients were there, like this involvement, extrahepatic spread was there, or the main portal vein involvement was there. And what this slide shows is that these difficult patients who are having MVI or extrahepatic spread, they showed a nearly doubling of median overall survival and progression-free survival, and nearly tripling of the overall response rate. If you see the response rate in sorafenib, it was like 10%, and this was nearly 30% in the atezo-beva. Similarly, the OS was 13.5 months versus 6 months, nearly doubling. So, updated OS and PFS, I will quickly go, as we have already covered this thing. It was improved, and this, as I said, it resulted in a median survival of nearly 19 months for patient of advanced stage hepatocellular carcinoma. So objective response rate, complete and partial. The complete response in 8%, partial in about 22% versus 11%. Stable disease in 44%, and disease control rate in as high as 74% of the patient. Importantly, the duration of response was 18.1 versus 14.9. So this is the updated response and duration of response. Again, if you see the duration of response, 18.1 versus 14.91. So if we talk about this OS benefit and the performance, the PFS benefit, so this was practically in all kind of patients, though the BCLC stage B, there was some doubt about the efficacy of atezo plus bev, and of course the controversial, the viral versus non-viral. So the viral, they did better, slightly better as compared to the non-viral, especially the hepatitis B and C. So atezo and bev practically was better in every aspect. So and another important thing which was covered in this study was the time to deterioration. And if you see the time to deterioration, it was 11.2 months versus 3.6, nearly tripling of that. And the safety concern, the diarrhea, PPE, decreased appetite, hypertension, we all know about these things, but important thing is as we are using the VEGF inhibitor, the chances of bleeding. So upper GI endoscopy should be done at least after 6 months of initiating the treatment to evaluate for varices. And if there was a history of upper GI bleed, then maybe 6 weeks or 3 months we can do a upper GI endoscopy. So upper GI bleed rate was about 7% versus 4.5 in this study, and serious adverse events that in this study was 38% versus in sorafenib about 30.8%, and discontinuation rate was 15 versus 10%. So the rate and grade of bleeding events in this study were similar between the treatment of, like in the reflect study, the lenvatinib, sorafenib, and if we compare all these things, the grade 3-4 bleeding rates was more or less same in all the studies. And this bleeding incidence, if we talk about specifically the IM Braves 150 study, so it was more or less same in both the studies, about 6%, and incidence of any grade bleeding was comparable in both the arms, 2.4% versus 1.9 in the sorafenib. And the rate of bleeding reported in previous bevacizumab trials was also consistent, and there was no incremental increase, this incremental risk of this bleeding in this. Another subgroup which was analyzed was the main portal vein, the VP4 disease, and again, if we see the overall survival, it was better. These are the difficult to treat patients or having the main portal vein thrombus or main portal vein invasion is there. Hazard ratio, if we see, that was 0.06, 0.62, and PFS was also nearly double with a hazard ratio again 0.62, and the bleeding tendency in both, if we see VP4 in both these things, the atezo-bev versus sorafenib, it was 6% versus 0% in sorafenib. So this effectiveness data for this atezo-bev and this AB real study again confirmed the trial of IM Power 150, and this median follow-up about 10 months, and this median treatment duration was 7.3 months, and any this adverse events, about 75% of patients had adverse event, and about 23% had the grade 3-4 adverse events. Attributable to atezo was about 20%, and bleeding events were in 8% of the patient. So in AB real study also, the bleeding events were higher in those patients who had LB grade 2-3 and Child-Pugh C, and those patients who had involvement of portal vein. So what about the Indian data, the real world Indian study? So it was a retrospective cohort of 67 patients, and it was presented by Kulkarni et al. And this was majority was having as we all know that the non-alcoholic fatty liver disease is more common in India. So majority had that thing, and 75% of these patients were stage C. So OS and PFS was 12 months and 8 months respectively, and overall response rate was achieved in about 38.7% of the patients. The OS and PFS, it was impacted by liver dysfunction, as was evident in other studies also, and nearly 2/3 of these patients were having the child B or C cirrhosis. Again, the adverse event, the grade 3 and 4 adverse events were noticed in about 20.9% of patients, including, as I have already told, child A, B, C respectively. So in child C, there were more adverse events as high as 85%. So 2 GI bleeds were there. One had a variceal bleed, another had a tumor thrombus in the main portal. So this study, the STRIDE study, which had Durva and tremelimumab, again it showed that there was an improvement in OS compared with sorafenib. This was 16.4 versus 13.8 months, and the hazard ratio of 0.78. And again, STRIDE study, we know that it both the arms, the experimental arm, it had a well-tolerated and acceptable adverse event profile, and very well tolerated. And again, the bleeding chances were lesser. And but it was the network meta-analysis. Dr. Amba was also discussing about this thing at a phase 3 study. Again, in this, the atezobev of IamBrave 150 was compared with other modalities. And this again, it showed that it was better compared to other modalities. So, important thing which comes into our mind is that is the disease etiology. It has a differential efficacy as far as the immunotherapy is concerned, and especially if we talk about the viral or the non-viral. So if you see the viral and non-viral, it's a controversial thing. Though the study shows maybe in the viral, these are more effective as compared to non-viral. But as far as the IamBrave 150 study is concerned, it was effective in both viral and non-viral, though better in hepatitis B as compared to non-viral disease. And again, an important thing which came out from this post hoc analysis was that overall survival difference was again same in NASH versus viral etiology. As we can see, 501 patient underwent randomization, about 336 patients they assigned to receive atezobev, and 57 they had legal regulation, 296 and 295 patients they underwent only the post hoc analysis, and these are the results. And if you see carefully, so both overall survival was more or less the same. If we talk about NAFLD, HCV, HBV, or alcohol-related disease. So atezobev, it has shown a benefit in the unresectable and advanced HCC as far as the real-world setting is concerned. There are real-world evidence to support that IamBrave data. For example, the AB real data, the Indian real-world data, and multiple meta-analysis which support this study. The post-hoc analysis of IamBrave 150 data, it has also shown that there is no difference in response to immunotherapy based on the etiology of HCC. Indian real world and this AB real study did not find any difference as far as the in the responses based on the etiology. IamBrave 150 and other phase 3 studies of systemic therapy were not powered to find the difference in the response based on the etiology. So any conclusion must be drawn with caution. So with this, I would like to thank you all for the patient listening. Thank you very much.
Thank you so much, sir. Very well taken, sir. Good presentation. Sir, I would like to ask one small question, sir. As we have seen, you have also very clearly mentioned that atezo plus bev has given lots of extra benefit over atezo monotherapy. So, would you be prompted to add bevacizumab to any other immunotherapy or immuno-oncology drug except for atezo? Like, would you, because Nivo now, because low dose Nivo is coming up with a great hype. So would you be prompted to add low dose, like for a patient who are not able to afford 20 mg Nivo plus bevacizumab, like that? Would you be
Theoretically, it is a possibility, but there is a lack of data, total lack of data. So I will refrain from that. And but important thing is, if the patient has a like VEGF inhibitor, patient is responding to treatment, but the patient has this like bleeding, epistaxis, repeated epistaxis is there, BEV induced. So what will we do then? Either we will continue with atezo alone, or we will add something else, and because we have to stop BEV if it is very symptomatic, the epistaxis. So the BEV combination with atezo, at times it can be troublesome, and GI bleeds are reported and can be there. So I don't know how you will treat an epistaxis, massive epistaxis of BEV.
no? Yes. So certainly we'll stop bevacizumab in case of
Yeah.
any active bleeding. So, thank you, sir. Thank you so much.
Sure. Okay.
So the next talk will be the last amongst the last speaker of this CME, because we have covered most of the important topics, but still renal cell carcinoma is still left out. So I would like to invite Dr. Megha, who is from the Department of Medical Oncology, Metro Hospital, Preet Vihar, to speak quickly in next 15 minutes on the optimal management or the recent guidelines in management of advanced renal cell carcinoma. Over to Dr. Megha.
Good evening, sir, and good evening, everyone. Thank you, Kapoor sir and Dubey sir, for giving me this opportunity. So,
Would you be sharing your slides?
yes, sir. Are the slides visible?
Yes, 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 yes.
So, I'll be speaking on renal cell carcinoma and evolving perspectives on optimal treatment. So, at the end of this talk, we should be able to identify patients with RCC who are most likely to benefit from targeted or immune checkpoint inhibitor-based combination therapies based on risk and biomarker assessment, along with patient medical and treatment history, to select optimal first-line treatment for individual patients with advanced or metastatic RCC, considering current and emerging options, available clinical evidence, expert recommendations, and patient preferences. Also, to plan evidence-based and expert-recommended therapeutic sequencing strategies, how to manage specific disease-related complications or adverse events, and also to select patients with RCC who may benefit from ongoing clinical trials based on tumor characteristics, previous treatment, and patient characteristics and preferences. So firstly, quickly talking about management of non-metastatic RCC at initial diagnosis. So for stage 2 patients, the primary treatment modality includes partial or radical nephrectomy, followed by surveillance or adjuvant pembrolizumab for grade 4 tumors with clear cell histology, and surveillance for non-clear cell. And for stage 3, it is radical nephrectomy or partial nephrectomy if clinically indicated, followed by adjuvant pembrolizumab for clear cell and surveillance for non-clear cell histology. So this table here summarizes the adjuvant immunotherapy trials in RCC, where Keynote 564 had compared pembrolizumab with placebo with benefit in terms of disease-free survival, with hazard ratio being 0.62. The other three trials did not demonstrate significant difference in terms of disease-free survival or RFS, where Prosper trial was stopped for futility also. So we'll be firstly talking about Keynote 564, which was a double-blind phase 3 trial, and the patients with histologically confirmed clear cell RCC who had underwent nephrectomy within 12 weeks prior to randomization with no previous systemic therapy, good PS, and PDL1 testing were randomized to two arms, pembrolizumab for 1 year and placebo. The primary endpoint was disease-free survival, which was met in first interim analysis, and the secondary endpoints being overall survival and safety. So it had also divided the patients amongst three groups: intermediate high risk, and M1 NED group, where the predicted DFS was 55 to 80% for intermediate high risk, 32 to 55% for high risk, and 3-year DFS was 20% for M1 NED cases. Talking about the result, so the patients who received pembrolizumab had better overall survival and disease-free survival in the ITT group over a median follow-up of 57.2 months, with hazard ratio being 0.62 and 0.72 respectively. However, talking about the risk groups, we can see that again, pembrolizumab had better DFS. But as we move ahead from intermediate high risk to M1 NED cases, we can see that the separation between the curves is much higher with M1 NED group. That also signifies that the benefit with pembrolizumab was more in M1 NED cases, with the hazard ratio being 0.28. Also, depending on the sarcomatoid status, if the sarcomatoid features are present or not, again, pembrolizumab had better disease-free survival, but the benefit was much higher if the features were present, with the hazard ratio being 0.54. Who should get adjuvant treatment? So we have to consider adjuvant pembrolizumab for patients with clear cell RCC with PT3 or higher disease, M1 NED within 1 year, and with collective urology, MEDONC, and patient determination. And pembrolizumab has also been approved by both FDA and EMA for adjuvant treatment. Now, what was not addressed by Keynote 564 trial was non-clear cell histologies, and also the choice of first-line therapy if there is progression following pembrolizumab. Now, what are the future directions and other unanswered questions? So the duration needed for adjuvant therapy is still unknown. Intensity of adjuvant therapy, risks, more toxicity and over-treating or under-treating the patients, and types of trials needed for validation of ctDNA, methylated DNA immunoprecipitation, or angiogenic or immune signatures. This table here summarizes the trials for adjuvant or neoadjuvant therapy in RCC, where LightSpark 022 had compared adjuvant pembrolizumab plus belzutifan with pembrolizumab and placebo, and Rampart had compared durvalumab with durvalumab plus tremelimumab. So coming to advanced or metastatic RCC first-line therapies. So as per NCCN, for favorable risk group, the category 1 recommendations include axitinib plus pembrolizumab, cabozantinib plus nivolumab, lenvatinib plus pembrolizumab. And for poor or intermediate risk group, axitinib plus pembro, cabozantinib plus nivo, ipilimumab plus nivo, and lenvatinib plus pembrolizumab are category 1 recommendations as per NCCN. Now, how do we stratify the patients in various risk groups? So we have IMDC criteria that comprises of 6 factors. That is KPS less than 80%, time from initial diagnosis to targeted treatment less than 1 year, hemoglobin less than lower limit of normal, calcium more than 10, platelet count and neutrophil count more than upper limit of normal. So if there are no risk factors, the patient is categorized to be favorable risk, which has the highest overall survival amongst the all. And if there are 1 to 2 risk factors, then it is intermediate. And if 3 or more risk factors are present, then it is categorized as poor risk group, which has the least overall survival. Now, overall survival with favorable risks. So as we can see that in these 4 trials, it was seen that the combination therapies did not demonstrate much difference as compared to single agent sunitinib in the favorable risk group. However, we'll be taking these trials one by one. So this table here again summarizes these 4 trials: Checkmate 214, Keynote 426, Checkmate 9ER, and CLEAR trials that had compared combination therapies with single agent sunitinib, and they had demonstrated better overall survival, progression-free survival, and as well as overall response rate. And also depending on the sarcomatoid features, if these are present, again, there was a much higher response in terms of ORR, median progression-free survival, and also median OS. Okay, so first, checkmate 214, where Nivo plus ipilimumab were compared with sunitinib. And as we can see that in ITT group and in intermediate or poor risk group, there was much higher advantage with Nivo plus Ipi as compared to sunitinib, and the hazard ratio was 0.72 and 0.69 respectively, and it was stable over the course of 8 years of median follow-up. However, in favorable risk group, we can see that earlier in the course of the disease, sunitinib had better overall survival than Nivo plus ipilimumab, but as the duration progresses, the two curves overlap, and then the Nivo plus Ipi, they show better overall survival as compared to sunitinib. So it improved over time in favorable risk patients. And in terms of progression-free survival and overall survival in ITT group, so this is keynote 426, where pembrolizumab and axitinib were compared to sunitinib, and we can see that progression-free survival was much higher with the combination therapy as compared to single-agent sunitinib, with the hazard ratio being 0.69 and 0.84 respectively. In checkmate 9ER, that had compared Nivo plus cabozantinib with single-agent sunitinib. Again, the combination therapy had demonstrated better PFS and OS as compared to sunitinib. And also the overall response rate was much higher with the combination therapy, 55.7% versus 27.7%. Then CLEAR trial had compared Len plus Pembro with sunitinib with better survival probability with the combination therapy. And also the ORR was much higher with the combination therapy, that is 71%. And the PFS was also much higher. So what are the key variables in treatment selection? So there is lack of predictive biomarkers in RCC. However, VHL is important for belzutifan, and IMDC risk stratification is to be done. Presence of variant histology has to be considered, that is sarcomatoid features if these are present or not. Time of relapse if patient has received adjuvant pembrolizumab, and patient preferences and other clinical characteristics. Now to summarize the factors that are to be considered. So the level of evidence supporting approved treatments, efficacy benefits, availability and quality of subgroup data, safety and tolerability, including risk of adverse events. Sorry. Okay. So, safety and tolerability, including risk of adverse events based on pre-existing conditions and prior treatment, impact on quality of life and treatment convenience. So this table here summarizes the select ongoing or recent phase 3 trials in advanced RCC, where LightSpark 012 is based on Pembro plus lenvatinib with or without belzutifan or covenlimab. Probe has studied immune checkpoint inhibitor combination, and Pedigree is based on nivolumab plus ipilimumab, followed by Nivo plus minus cabozantinib. Coming to post-immune checkpoint inhibitor therapy, so second-line therapy and beyond. So if the patient has already received frontline TKIs, so the options following those include axitinib plus pembrolizumab, cabozantinib, cabo plus nivo, evero plus len, ipilimumab plus nivolumab, lenvatinib plus pembrolizumab, and also single-agent nivolumab. However, following frontline immunotherapy, the options include axitinib, belzutifan, cabozantinib, len plus evero, and tivozanib in third-line setting. So this slide again summarizes the same. Now, what are the clinical trial data supportive of sequencing VEGF therapies before the era of IO combinations? So these 4 drugs, axitinib, nivolumab, cabozantinib, lenvatinib with everolimus, these have been compared with sorafenib and everolimus in second-line or TKI refractory settings, and we'll be taking these one by one. So phase 3 Meteor trial had compared cabozantinib with everolimus, and it was seen that cabozantinib had better overall survival as well as ORR 17% as compared to everolimus alone. And here we can see that lenvatinib plus everolimus was compared with single agent lenvatinib and everolimus. However, the combination of lenvatinib and everolimus had better overall survival as well as better overall response rate, that is 43%, as compared to single agent lenvatinib or everolimus. Now, coming to activity of VEGF following checkpoint inhibitor therapy in frontline. So this table here summarizes the VEGF TKI efficacy. So these trials had compared axitinib and various other drugs in second line or third line settings, comprising of axitinib, cabozantinib, pazopanib, sunitinib, or again axitinib. So Cabo Point is an ongoing non-randomized international open label phase 2 study which had studied cabozantinib in ICI refractory setting with the primary endpoint being ORR. So the patients were divided into two cohorts, EP plus Nivo and IO VEGF TKI, where the ORR was better with EP Nivo group as compared to the other cohort. Then again, this keynote trial was a phase 1b/2 study where patients had already received 0 to 2 lines of previous therapy. And it was seen that the patients who had previously received immunotherapy had better overall response rate at 24 weeks as compared to IO naive cases. And also the partial response was higher with the previous IO group, and the stable disease was higher in IO naive group. TO3 is an open label randomized phase 3 study where patients had already received 2 or more previous systemic treatments, and it had compared tivozanib with sorafenib, and where tivozanib had demonstrated better progression-free survival and overall response rate as compared to sorafenib alone. And it is indicated for the treatment of adult patients with relapsed or refractory advanced RCC cases following 2 or more prior systemic therapies. So LightSpark 005 is another trial, another phase 3 study where patients had received 1 to 3 prior systemic regimens, and it had compared belzutifan, which selectively binds HIF2 alpha and prevents its heterodimerization, with everolimus. So as we can see that early in the course of the disease, there was not much difference in terms of PFS and overall survival. But as the duration increases, as we move ahead, there was a much higher advantage in terms of PFS and OS with belzutifan as compared to everolimus. Now, the ORR was much higher with belzutifan as compared to everolimus alone, and the same goes for complete response or partial response. So belzutifan has been approved by FDA for advanced RCC following PD-1, PD-L1 inhibitor and VEGF TKI. Talking about the safety profile, so belzutifan is known to cause more anemia and hypoxia as compared to everolimus. And everolimus, however, causes more cough, rash, stomatitis, hyperglycemia as compared to belzutifan. Now, belzutifan can cause severe hypoxia that may require discontinuation, supplemental oxygen, or hospitalization, where we might have to withhold the drug or resume at reduced dose or discontinue depending on severity of hypoxia. And we might have to permanently discontinue it if there is life-threatening or recurrent symptomatic hypoxia. And it can also cause severe anemia that may require blood transfusion. So if the hemoglobin is less than 8, or if the transfusion is indicated, then we may have to withhold the drug or resume at the same or reduced dose or discontinue it, depending on the severity of anemia. Now, should ICI therapy be continued in patients refractory to IO frontline combination? So this table here demonstrates the 3 trials that had studied IO continuation in IO refractory disease. So Omnivore, Titan RCC, and XCRN-GU16 had studied the patients who had stable or progressive disease after receiving prior immunotherapy. And it was seen that there was a certain subset of patients which had received partial response or even complete response after IO continuation. However, there was this study which had uh, which had demonstrated that there was not much difference in terms of median progression-free survival or 12-month PFS when cabozantinib was compared with atezolizumab plus cabozantinib. So TiNivo 2 is an ongoing phase 3 trial in the post-IO setting where it was a multi-center randomized open-label phase 3 study where adult patients with clear cell RCC who had progressive disease during or following 6 weeks of treatment with an IO therapy with 2 or less previous lines of therapy were randomized to 2 groups, tivozanib plus nivolumab or tivozanib alone until progressive disease or unacceptable toxicity. So, the primary objective is PFS, which has not been met yet, and the secondary endpoints being OS, ORR, DOR, safety and tolerability, etc. So, what are the considerations for treatment after progression? So, the treatment options are guided by previous treatment received, strength, comorbidities, patient and provider preference, and so various therapeutic options can be used to sequence therapy at each progression, depending. We have to strategize post-progression treatment sequencing, considering the treatment history, strength of evidence, adverse event profile, patient comorbidities, preference, and thank you.
Thank you, Dr. Megha, for explaining all the available options in localized, locally advanced, and metastatic RCC. So with this, I would like to thank each and everyone here who have spared their precious time for joining this small CME. And also, I would like to thank organizers without whom it would have been impossible to organize such gathering. So I conclude here. Over to organizers. Thank you.
Thank you, Dr. A.P. Dubey, for organizing this conference. And thank you to all the faculty